So thank you everyone for joining us for the 7th Molecular Oncology Society Conference. Without wasting any further time, I would now request our Program Director, Dr. S Krupashankar, to please give the welcome now. Over.
Thank you. So very good evening and a warm welcome to everyone who's logged in. So first of all, I must tell you that this has been a great effort from the entire team to actually put together the 7th edition of the Molecular Oncology Society of India National Conference, which happens every year. So this year, the theme of the conference is basically on molecular oncology and how do you translate the evidence into practice. So I think that's been a big caveat because we all keep talking about how precision medicine has evolved over the years, but how do we actually put all the data that we have and actually apply that into practice? So I think that's going to set the tone for the entire conference. We have split it over 4 days and we have a couple of sessions on each day, just so that we keep all of you engaged. We have a huge list of eminent speakers from all over the country to take us through, and we have debates on each topic, and we have a guest lecture and followed by a panel discussion for each topic. So today on day 1 we kickstart things with discussions on sarcomas, neuroendocrine carcinomas, and then gynae oncology as well. So I'm looking forward to a great academic feast as always, and glad that our patron Dr. Purvish sir has also joined us. Thank you, sir, for logging in. Looking forward to hearing from you as well, sir, through the conference. So without any further ado, Kashish, I'll hand it over back to you, Kashish.
Thank you so much, sir. We'll now move on to the first session. Our first session is sponsored by eSci, and the topic is role of Eribulin Mesylate in the management of advanced liposarcoma. And our first speaker is none other than Dr. S Krupashankar, medical oncologist from Coimbatore. Over to you, sir.
Thank you, Kashish. I'll just share my screen and start. Well, hope my slides are visible.
Yes, the slides are visible.
All right, thank you. So a very good evening to everyone, and like I said, this is a sponsored session by eSci. So I'm going to take you through the systemic therapy for advanced soft tissue sarcomas, with the spotlight being on Eribulin. So we all know that obviously soft tissue sarcomas, there are about more than 50 subtypes, and they vary in their molecular, histological, and the clinical characteristics as well. And they can occur at any site, but predominantly mostly in the extremities, followed by the trunk, head and neck, and retroperitoneum in that order. And the most common subtypes, especially if you look at it in India, are the L-type sarcomas, which is both leiomyosarcomas and liposarcomas. But the undifferentiated pleomorphic sarcomas, synovial sarcomas, and MPNSTs are much more common in Western countries as opposed to in India, whereas in India, the most commonest variant is still the L-type sarcomas. It's very rare. It accounts for less than 1% of all adult cancers, and up to 50% of patients with high-grade sarcomas can develop metastasis and die or succumb to their disease. So if you look at the burden of the disease in India as well, it's almost on par. Like I said, it accounts for less than 1% of all cancer cases, and extremities being the most common site. Lower extremities more commoner than the upper extremity, and in India specifically, most of them present with an advanced tumor size of at least more than 10 centimeters, or a T3, as if you look at the recent AJCC 8 staging system. Earlier it was only less than 5 centimeters and more than 5 centimeters. Now you have cutoffs of 5, 10, and 15. So that's for T1, T2, T3, and T4. That's another change that's happened in soft tissue sarcomas. And more often they are intermediate to high grade as well, and male sex seems to be more predominant. So if you look at the common histological subtypes, and this is across the globe, like I said earlier, the L-type sarcomas are the most prevalent and the most common subtypes, followed closely by the undifferentiated pleomorphic sarcoma, which was earlier known as MFH, or malignant fibrous histiocytoma, now no longer known as MFH. It's undifferentiated pleomorphic sarcoma. And again, the most common sites being the extremities and the lower extremity, followed by the upper extremity in that order, and then the other organs. So this is a study looking at the most common or prevalent subtypes in India specifically. And like I mentioned earlier, again, the most common subtypes were liposarcoma and leiomyosarcoma, 25, and they accounted for about 1/3 of the entire histological subtypes. So what are the key determinants that we actually take into account before we select systemic therapy for patients with advanced or metastatic soft tissue sarcomas? Definitely the histology plays a role, very important role here. Histology-driven therapy is here to stay as far as metastatic sarcomas are concerned. And again, the prior therapy also matters, and all the performance status of the patient. And when you look at your goals of treatment, obviously you're looking at extending the survival with also maintaining the quality of life as well. And patients who are very symptomatic, probably a double agent chemotherapy would actually be better because you're looking at more rapid responses, and the response rates are higher with a doublet as opposed to a single agent anthracycline. So what are the options that we're left with? Again, we had the EORTC triad, which looked at adriamycin or doxorubicin along with ifosfamide, or the AIM regimen as we know it. But again, the addition of ifosfamide really didn't seem to impact on the survival, but the response rates were higher with the combination. Gemdosi is another option in the first line, again based on the JEDIS study. And again, the other second line options are eribulin, prazosinib, trabectedin, and gem plus dacarbazine. And I'll take you through that as to how we choose between those options as we move along. So these are all the first line studies that were done. The URTC study, the Picasso study, which looked at ifosfamide, and then ifosfamide as well, which was looked at in the SARC-21 trial, and then the British JEDIS study, which looked at gemdosi versus doxorubicin. They could not really prove superiority of gemdosi compared to adriamycin or anthracyclines. So as I was talking to earlier, this was the URTC study, and you can see here, even though that there was a numerically significant improvement in the survival of around 2 months, this was not statistically significant. And hence, but the response rates definitely were higher with the doublet as opposed to a single agent, which is why probably if you have somebody with a high volume of disease or a high burden of disease, and if you want a rapid response, then you're looking at using a doublet in the first line. Otherwise, anthracyclines alone are good enough. And this was another study which looked at ifosfamide. Unfortunately, again, a negative study. Ifosfamide is nothing but a new congener of ifosfamide. And they've looked at different another congener called ivofosfamide as well. Unfortunately, this was also another negative study. So, and hence the reason as to why these are not approved options. So either anthracyclines or ifosfamide with adriamycin, or the AIM regimen as we know it. So moving on to the JEDIS study, this was one of the very highly anticipated trials that was being looked at, a phase 3 RCT of gemdosi, because people really believe that leiomyosarcoma, gemdosi is any day a better option. But unfortunately, if you look at, based on a subgroup analysis from the JEDIS study as well, even in leiomyosarcomas, gemdosi did not seem to outperform anthracyclines or adriamycin, and which is probably why anthracyclines still remain the agent of choice if you're looking at it in the first line setting. And gemdosi may not actually have any sort of a survival benefit when compared to anthracyclines. And then came the other blockbuster drug, which was olaratumumab. So that's a monoclonal antibody that binds to the PDGFR, a platelet-derived growth factor receptor alpha. And again, the phase 2 data was really promising, and people were looking at it. And this actually got an accelerated approval as well from the FDA to be used in combination with anthracyclines. But then came the big blow. This is probably a learning curve and a lesson for all of us, that don't change practice based on only phase 2 data. Wait for phase 3 data to be mature as well. Because then came the results of the announced study, which was a phase 3 study presented on ASCO plenary session. And again, here the primary endpoint of overall survival was not met, either be it again in the intention to treat population or even in the LMS subset as well. And subsequently, then the FDA pulled the plug on this drug, and it no longer remains an approved option. So that was a big blow for olaratumumab. So again, just to conclude on the first line setting, anthracyclines alone are good enough. Consider adding ifosfamide in somebody who's got a large volume of disease, or somebody who's very symptomatic, because the response rates are better. Gemdosi, not necessarily. You don't have to necessarily give them in the first line setting. You can reserve it in the second line. So how do you choose in the second line setting? I think it's got, again, like I was alluding to earlier, it has to be a histology-driven approach in the second line setting. So we know for liposarcomas or the L-type sarcomas, both eribulin and trabectedin are wonderful options that we have access to. And now that we have generic options available for both eribulin and trabectedin, so that's the standard of care for. But as far as non-liposarcomas are concerned, again, pazopanib is a good enough option based on the pellet study, which I will touch upon. And then again, for other non-histologic specific sarcomas, you could look at gemcitabine-based regimen, either be it in combination with dacarbazine or even in combination with docetaxel. So these were all the gem-based combinations that we looked at: gem-dosi, gem-dacarbazine. Again, most of them phase 2 data that we have, especially looking at it in leiomyosarcomas, all of them had a similar magnitude of benefit. So hence, if you're looking at a leiomyosarcoma, probably in the second line setting, you could definitely use a gem docetaxel. And this was another study which looked at the combination of gem and dacarbazine versus only dacarbazine. This was again phase 2 data. This was again data. And again, if you look at it, definitely the combination seemed to be doing much better. Look at the median overall survival, which was doubled, 16 versus 8 months. The hazard ratios were also pretty strikingly improved at 0.56. So I think that's a real that's the data that we have as far as doing a combination in the second line setting. So gem dacarbazine over just single agent dacarbazine seemed to do better. And this was the pellet study, which looked at pazopanib in patients who had progressed on multiple lines of therapy. This was the phase 3 data, where the comparison was with placebo. And again, I think one drawback with the study is they did not include patients with liposarcoma. So this was only in patients with non-liposarcomatous histologies. So again, there was an improvement in the PFS of close to 3 months, absolute benefit of 4.5 versus 1.5, and median overall survival also absolute benefit of around 2 months. So moving on to Eribulin, I think we've heard a lot about the drug in recent times as well. It's an antimitotic drug and a spindle agent as well. So it brings about vascular remodeling, and then it also causes an arrest in the G2 to M phase of the cell cycle. But most importantly, it causes a reversal of the epithelial mesenchymal transition, what we call as MET, or mesenchymal epithelial transition. And that's one of the reasons as to why it's been postulated or hypothesized that, or given most of the data with Eribulin, where we don't get to see a PFS benefit, but we get to see an overall survival benefit. And that's because the MET, or the reversal of EMT, happens a bit later on. And that's probably one reason as to why we get to see that. So this was the data which looked at Eribulin versus dacarbazine, again in advanced L-type sarcomas, both leiomyosarcomas and liposarcomas. And clearly, as you can see here, in both those specific histologies, the magnitude of benefit was higher, and specifically in liposarcomas as opposed to leiomyosarcomas. Look at it. If you look at it again, 13 versus 11 months, an absolute improvement of around 2 months. And again, when they broke it down based on the histologies, liposarcomas seem to do much better. And that's why it's, if you look at the ESMO magnitude of clinical benefit scale, also it's got a high rating, MCBS score of 4. And this was consistent across all the different subtypes of liposarcomas, be it the myxoid, round cell, and the pleomorphic, which we know are pretty high-grade liposarcomas, and dedifferentiated as well, surprisingly, because we always talk about that as not being a very high-grade. Dedifferentiated liposarcomas also seem to benefit from Eribulin. So again, this is what I was alluding to. ESMO's gotten the magnitude of clinical benefit scale, has given it a score of around 4, and the absolute improvement in overall survival of 7 months. So it's got a very strong recommendation in liposarcomas. Moving on to the other drug, which is trabectedin. Again, this was also compared with dacarbazine, and this also seemed to do well, especially in the L-type sarcomas, but probably in leiomyosarcomas had a bit of an edge, I would say, even over Eribulin. But in liposarcomas, Eribulin still holds the edge. So, and again, this was interesting real-world data looking at translocation-related sarcomas, be it in myxoid and round cell liposarcomas, where trabectedin seemed to maintain its magnitude of benefit. And across all subsets, and predominantly the leiomyosarcomas and the liposarcomas, data for trabectedin also, as far as the median PFS and median overall survival, the data was really good. And just a brief cross-trial comparison between all the 3 drugs that we've used in the second line, Eribulin, trabectedin, and pazopanib. The primary endpoint was met both in the pellet study and in the study for Eribulin. But unfortunately, the trabectedin study, the primary endpoint of OS was not met. But the PFS benefit was actually shown in that study. And again, the other criticism about the pazopanib study or the pellet study is that they did not include patients with any liposarcoma. They only looked at non-liposarcoma. So if you have a patient with liposarcoma, you have a lot to choose between trabectedin and Eribulin in the second line. And like I said, probably the way I would look at it is Eribulin for liposarcomas, and probably trabectedin would be an option for leiomyosarcomas as well. But again, then how do you choose? Again, I think you would also have to look at the ease of use, because we know trabectedin has to be given as a 24-hour infusion for sarcomas, whereas in ovarian cancer, you give it as a 3-hour infusion. So that's one thing we'll have to watch out for. And Eribulin,
Sir, 2 minutes left, sir.
Yeah. Sure. Eribulin probably much easier to handle as well as a drug, so that you could choose it based on the toxicity profile as well. So again, if you look at the regimens, obviously the NCCN also recommends both trabectedin and eribulin. It's got a category 1 recommendation for both lipo and leiomyosarcomas. Aldoxorubicin, again, another drug which was looked at, probably because they looked at lesser cardiotoxicity, but unfortunately, did not end up being approved. Selinexor, we've heard a lot about this drug, Nexpio antagonist and a SINE inhibitor or selective inhibitor or nuclear exporter. It's been approved in myeloma as well, but unfortunately, here we're still waiting on phase 3 data. So the phase 2 data has been promising. We'll have to wait for phase 3 data. So again, the treatment considerations for second line, you'll have to look at the histology-driven therapy, definitely liposarcomas, probably eribulin, leiomyosarcomas, probably trabectedin has an edge. Non-liposarcomas, pazopanib is as good. And for leiomyosarcomas, you could do gemdositaxel and then put them on eribulin. So again, this is just to sum it all up. And I can't probably end without touching on immunotherapy because that seems to be the flavor of everywhere across the globe. So again, we've had very early data on immunotherapy as well, even in sarcomas, phase 2 data from the SARC study, and then Nivo-EP, the combination IO plus IO. But again, this is all very early data. The response rates seem to be very promising, but we'll have to wait for the survival data as well. So to sum it up again, histology-driven therapy depends definitely on the histological subtype. So pazopanib, except in non-liposarcomas, it's a good option. For pecomas, mTOR inhibitors, for angiosarcomas and desmoid tumors, again, sorafenib, ASPS, sunitinib, epithelioid sarcomas, tesimetostat, which is a EZH1 inhibitor, has been approved now. Cediranib for, again, ASPS, solitary fibrous tumors, temozolomide and bevacizumab, and Palbo for dedifferentiated liposarcomas, and the recent approval for tenosynovial giant cell tumor, which is pexidartinib, which is a CSF1 receptor inhibitor. So again, there's a whole lot of studies which are ongoing looking at combinations. And that probably seems to be the way forward, especially in combination with the immune checkpoint inhibitors. So we'll wait for all those data to be mature. So promising times ahead. So with that, I'll conclude and say thank you all for your patient listening. And back to Kashish.
Thank you so much, sir. We've received a question from Dr. Hemant on the chat box. Request you to reply to the same. We'll move on to the next topic. And our next topic is basics of setting up a molecular tumor board, pros and cons. And our speaker is Dr. Parikh, precision and medical oncologist from Mumbai. Over to you, sir.
Thank you very much, Kashish. Thank you very much, Krupashankar, for inviting me to give this talk. I think it's very relevant talk in this Molecular Oncology Society conference. So let me start that. If you look at what Times of India mentioned a few years ago, that cancer is increasing 5-fold in India by 2025, and 25 is just 3 years hence. And then if you look at the number of preventable deaths, you can see that a large number of them are actually happening in India. So if you put these two together, we have a big role to play. And our quest has always been to improve outcomes. As you can see, probability of overall survival in this particular disease, cancer, it has increased from 8% to as much as 96%, but we are still not satisfied with the outcome. And when we want to improve outcome, we must understand that what we have been constantly doing so far is not going to help us get up further. We have to do something new. And that new thing is to convert a tumor board into a molecular tumor. And I'm sure all of you are very familiar with this figure. What happens if you have to give treatment to a tumor board without molecular testing? Same doublet chemotherapy needs to be given to all patients. Whereas after molecular testing, you can clearly see that there is a host of benefit because we positively identify patients who are targets for targeted therapy. So tumor boards are the most systematic, reliable, and proven methods of a second opinion. And why? Because they systematically look at the biopsy, the sequencing, the alignment, the annotation, interpretation and reporting, and then put everything together for the benefit of the patient. So landscape of actionability is constantly changing and evolving as far as molecular oncology is concerned. We have large number of new approved targeted therapies. There is updates to clinical guidelines, and Krupashankar just mentioned the NCCN guideline for STS. We have new clinical trials which are looking at targeted therapies. And there are mutations that contribute to cancer in many ways, increase the risk, increase the chance of development of cancer and progress, and what happens ultimately to response to therapy. And pharmacogenomics is underrepresented, something that we often miss out, where genetic alterations response to particular drugs are based. And I think we have two very big stalwarts, Amit Verma and Sevanthi Limaya, who are doing molecular tumor boards on a regular basis. And I must congratulate them for ensuring that there is capacity building in our community. Now, how to survive this ocean of new information? We all agree that there is overload of data. We also know that there is significant ethnic variations, and I will show you some examples of the same. Interpretation, therefore, needs customization. And there are also an immense collection of variations whose significance we don't know or we need to find out. Just to take an example, if you have 4 NGS machines, each one has its different capability, each one has its pros and cons, and we need to ensure that we select the right test when we want to do the molecular evaluation. So you must have the right expectations, the right test, and the right results. Otherwise, what will happen? What will happen is what is shown on the right-hand side, that these thieves were caught. They went into the bank to steal the ATM machine, but they came out with the passbook printing machine. And this sort of embarrassment should not happen to us. So right expectations is whether we are looking for a common or rare mutations, whether there are specific mutations or we are doing an exploratory analysis, whether it's germline or somatic mutations, and whether we are looking at NGS for a solid tumor or doing a liquid biopsy. The right test depends on whether it's DNA or RNA, whether it's hotspot or comprehensive genomic profiling, whether the mutation or alteration is small versus medium versus large, and so on and so forth. And the right result is whether it's a true positive versus a true negative, whether depth and coverage are appropriate or not. So to take an example of BRCA1 and 2, you can see this is a large number of data that is collected from all over the world. 18,435 families with BRCA1 mutations, 11,351 families from BRCA2 mutations, 69 centers from 49 countries and 6 continents contributing to this huge data. And this is data from 2018. It has obviously moved further. And what is the significance of such a data? If you look at a specific mutation, this is the result that I got for one of my patients. There are 1,998 deleted variants that match your search. Now, unless we have a molecular tumor board, I don't think we will be able to evaluate this correctly. Top of it is ethnic variation. So you can see this in this particular instance. Hispanic Latino is on the top, Asian is in the middle, and African American is at the bottom. And you can clearly see that there is a difference in the weight. This is for lung cancer, and again, you can see that the Asians versus Caucasian, there is a significant difference in the percentage of patients who have specific mutations. And this is something that we published way back in 2013, and that is the geographical map of ethnic variation in EGFR mutations in non-small cell lung cancer, varying from about 5% in the Caucasian population to as high as 50% in the Koreans and Taiwanese. Once you identify the mutation, we should also know how to interpret the risk of cancer in this mutation. And that risk is not static. It changes with age. And you can clearly see that in this particular instance, as the age increases, the risk is increasing. So unless you have a molecular tumor board, we will not be able to tell the patients exactly what the risk is. So besides what as a composition of tumor board, a molecular tumor board must be set up to add the following specialists: molecular geneticist, genetic counselor, data scientist, and a biostatistician. And I think all 4 are really important. We should also have a chairperson and secretary. The frequency of meetings need to be decided. Whether it's an in-person, virtual, or hybrid is important. And I think most people would follow a hybrid model right now because it helps or enables a larger audience, a larger participation. Now we come to the meat of the thing, and that is the case details. Unless there is a molecular testing done and report available, that case should not be discussed in a molecular tumor. Details of the case and the molecular testing report should be circulated in advance to the participants. The person requesting the discussion of the case should be present to make the case and answer questions from the tumor board. And patients may request the case to be discussed but cannot attend the molecular tumor. Finally, after the discussion is over, there is to be a proper documentation of the decision and the recommendation. So this is how a molecular tumor board needs to function. Now, this is the workflow of the molecular tumor board, and at any space, if the criteria for discussion in the molecular tumor board are not met, the case needs to be rejected and not discussed, because otherwise we'll be wasting everybody's precious time. So if the patient or the case is not appropriate, or the report that is available is inadequate and not reliable, these are flags for rejecting a case from a molecular tumor board discussion. Krupashankar mentioned the NCCN guidelines, and here I am showing you a similar thing. Principles of molecular and biomarker analysis is part of the guidelines for 2021 for non-small cell lung cancer. And besides the mutations, we also look at PD-L1 and circulating tumor DNA, which are now an inherent part of all these discussions. Now, somebody might say that what about Shiva trial? It did not show any benefit. And what is this all big things about doing a molecular tumor board if the patient is not going to benefit, if there is no actionability of this? So let me look at this particular publication of 2020 by Sumay Kato and others. And this is 715 unique patients discussed in 200 meetings of a molecular tumor board between December 2012 and September 2018. And very interestingly, 58 physicians presented more than one case. And this green and red line clearly proves the real world benefit of a molecular tumor board. If the matching score is 50 to 100% in the green line, the survival, overall survival is much better than if the matching score is 0 to 50%. And I'll explain to you what this means. So this tumor board discussion was matching patients to drugs, which was feasible after a MTB discussion. And this was possible in 62% of the patients. So if half or more patients are benefiting, I think this is an immense value that molecular tumor boards are contributing. Compliance to molecular tumor board recommendation improved progression-free survival with a hazard ratio of 0.68 and a p-value of 0.008, and overall survival with a hazard ratio of 0.69 and a p-value of 0.036. Obviously, high matching scores lead to better clinical outcome, and that is shown in the subsequent slide. So the patients were divided into 4 groups based on matching scores. Group A were 75 to 100% matching. Group B were 50 to 74% matching. Group C were 25 to 49% matching. And Group D were 0 to 24% matching. And this is the matching of more than 50% on the left column versus matching of less than 50% on the right column. And you can clearly see that the number of patients with complete remission increased from 1% to 2.5%. The number of patients with partial remission or stable disease increased from 24% to 49%. And the number of patients with progression disease or stable disease less than 6 months reduced from 70% to 48%. There are other publications, of course, that show the benefit of molecular tumor board. You can see in onco targets, you can see in trends of cancer, as well as the entire chapter in the ASCO educational booklet. So I need not say more about the benefits of a molecular tumor. So is there a downside to molecular tumor board? And assuming that the test results are reliable and done from a quality laboratory, the downsides are as follows. doctors need to find time in their busy schedule to pay attention and attend the molecular tumor board. Hospitals need to allocate resources, both in terms of time, space, as well as data. Patients, I think, are very important, and we have to look at the downside so that we counsel them properly before we take them for molecular testing and discussions. There is a lot of anxiety before and after the molecular tumor board. There could be a delay in initiating therapy till the tumor board meeting happens. There will be guilt about not being able to procure recommended treatment if it is expensive or beyond the reach. And there is always a need for additional follow-up and tests to see whether the patient is responding to the treatment given. For everybody, we have to remember that it's a dynamic science with a new information coming available almost every day. It is challenging to apply meaningful data in today's day and age to the patient in real time. And then there's downside that has been published in 2018 that sequencing cancer tumors hold more promise than proof. So there are views on both sides. In summary, I believe that I strongly support molecular tumor boards because they help navigate and understand complex NGS reports. They help translate molecular alterations into genuine clinical indications. Video conferencing allows us to have access to global experts in case there is a complex or difficult case. And there is a more extensive personalized oncology management possible. The goal is to determine and recommend the best possible cancer treatment plan for an individual patient. This recommendation by the molecular tumor board is not binding on the treating oncologist or the patient. This is just a recommendation. After all, they have to then decide whether to follow it or not. Also, please remember that making such a recommendation does not lead to any medical legal liability to the members of the tumor board. So we should really feel safe and give our frank opinion on what needs to be done. With that, I thank you very much for a patient hearing. And if there are any questions on the chat box, I will respond to that. Over to the organizers.
Thank you so much. Thank you so much, sir. We'll move on to our next session. This session is on sarcomas and NEC. And our first topic is histology-driven therapy for soft tissue sarcoma in clinical practice. Our speaker is Dr. Padmaj Kulkarni, Senior Medical Oncologist from Pune. Over to you, sir.
Thank you very much, Dr. Kashish. Can I share my screen? Yeah.
Yes, sir. Please go ahead.
Yeah. Good evening, friends. Today I'll be discussing about histology-driven therapy for soft tissue sarcomas. As Dr. Krupashankar has nicely taken care of the WHO classification. There's a histological diversity of soft tissue sarcomas, and WHO classification broadly classifies them into these groups. If you see the classification, there are tumors of adipose tissue, fibrohistiocytic tumors, and tumors of uncertain histology, so on and so forth. If to make the slide slightly easier to understand, this is a chart which shows that the liposarcomas, a couple of types, leiomyosarcomas and undifferentiated pleomorphic sarcoma make the major part of it. There's some other less common types, and then all other types of the 50-odd types are amalgamated together into this group of others. This is the list, as you can rightly expect, because there are more than 50 types of sarcomas. So you expect a lot number of drugs to be involved in their treatment. So this is a big list. This is a table which summarizes the common drugs which are used, like doxorubicin, then combination with ifos, gemdosi, dacarbazine, eribulin, etc. There have been meta-analysis also which have suggested a role of chemotherapy. Now, as you can see over here, one size fits all has been the thinking behind the treatment till now. But we are all unique with individual needs and requirements. The tumors also are are different and the needs are different. So the problem of one-size-fits-all approach is all soft tissue sarcomas were treated as one entity in the previous trials. The rare diseases also were included in trials, they are clubbed together. Because of this, the trials were underpowered to study each subtype and the outcomes were compromised. Then we realized that the various sarcomas are heterogeneous by way of molecular subtyping. Also, you can see various tumor types represented in this, and there is a lot of heterogeneity. A detailed study of the tumor genotypes showed that there's some sarcomas associated with specific mutations like Ewing's PNAT with 1122 translocation, synovial sarcoma at 18, alveolar RMS with 113 and 213, DSRCT with 122. Some sarcomas are associated with kinase mutation, gene inactivation. Some are with simple genetic alterations and complex genetic alterations. So now we know that histology is important, but it may not be sufficient. It may change with the pathology, so you need to have good pathologists with experience in sarcoma. You may require IHC, which also may not be sufficient, and that's why molecular subtyping may be needed, which again may not be sufficient, as we'll see. So when we start thinking about treatment of sarcomas, the first class in your practice, the first thing to be thought about is whether they are anthracycline sensitive. This is the list, the histology of tumors which are anthracycline sensitive: synovial sarcoma, liposarcoma, leiomyosarcoma, angiosarcoma, undifferentiated pleomorphic sarcoma, MFH, and MPNST. If the first line therapy was doxorubicin alone, the second line can be gem-dosi or single agent IFOS, pazopanib, dacarbazine. For LMS, trabectedin and eribulin also is used for liposarcoma. IFOS is useful for synovial sarcomas and myxoid round cell and pleomorphic liposarcoma. So this is a big list which will show you that tumors are being increasingly treated depending on the histology. So the change is the only constant thing in life. So right from the thought process of coming to one size fits all, we are now moving to individualized treatment, starting with histology, then coming down to molecular phenotype and genotype for a particular tumor. So one particular tumor may have two different genotypes and we may need to treat that tumor differently. So now we started thinking about sarcomas in different types divided by their treatment directed intention. So some could be chemosensitive, some are moderately chemosensitive, and others are resistant. Coming to chemotherapy sensitive, synovial sarcomas, for example, the treatment recommended is doxorubicin plus minus ifosfamide or trabectedin, and targeted therapy could be pazopanib. For myxoid round cell LPS, doxorubicin or epirubicin combined with ifos, dacarbazine alone or combination, and trabectedin can be used. While WD or DD, differentiated LPS, the same combination with doxo plus minus ifos or trabectedin can be used, while targeted therapy can be palbociclib. Angiosarcomas, weakly paclitaxel has been found to be active, and targeted therapy could be pazopanib, sorafenib. Now, these tumors are chemotherapy sensitive. The other class could be chemotherapy plus anti-angiogenic therapy sensitive sarcomas. The example is solitary fibrous tumors or hemangioperisatomas. These are the drugs temozolomide plus bevacizumab or doxorubicin plus dacarbazine combination, dacarbazine, single agent, or trabectedin. Coming down to tumors which are resistant, this is a peculiar class wherein we need more alternatives like picomas, which are found to have TSC1 and 2 genes which are involved, and in these patients, sirolimus and temsirolimus, which are mTOR pathway acting drugs, are effective. Alveolar soft tissue sarcomas usually are treated with AKT or MAKE pathway drugs like sunitinib, cediranib, pazopanib, and tivantinib, which are MET inhibitors. This drug is MET inhibitor. IMT has got ALK, ROS, and rate changes, and that's why crizotinib and ceritinib have been found effective. Clear cell sarcoma, translocation 1222 is common, and tivantinib and crizotinib has been found to be effective. So as we see, there are different drugs chosen based on specific genetic mutation, and depending on which pathway is found out, you can use different drugs. Immunotherapy drugs have also been found to be useful. There is high TMB with greater PD-1 and PD-L1 expression in the soft tissue sarcomas, though the percentage varies from type to type. It is especially more in undifferentiated pleomorphic sarcomas, and that's why there is a lot of hope in using immunotherapy drugs. A couple of trials, Krupashankar also had covered them. SARC 28 and Alliance trial. The percentage of response, objective response was 18%, and about 15-16% in another trial, Alliance trial. So coming forwards, we expect a lot of trials coming up using chemotherapy drug with targeted therapy or immunotherapy drugs. So coming down to what you do in your practice, a patient comes to you. First thing you decide is histology, whether it is chemotherapy sensitive or resistant. The most frequently occurring subtypes are more sensitive to chemotherapy. You also need to decide whether patient has failed a previous regimen, patient fitness, and goals of the therapy. The first line treatment for chemotherapy sensitive disease is either single agent doxorubicin or a combination of ifosfamide and doxorubicin if more aggressive therapy is required. A second option for these patients could be gemcitabine docetaxel. It also can be used if doxorubicin is not is contraindicated in these patients. It can also be used as a secondary option on progression. And this is a list wherein, in addition to the factors mentioned, you consider histology to decide the tumor, the treatment. For example, clear cell sarcoma, as I mentioned, crizotinib, LMS and liposarcomas, trabectedin, liposarcomas, eribulin, angiosarcomas, single agent taxanes, pecomas and endothelioid, hemangioendotheliomas, sirolimus, PVNS, that is pigmented villonodular synovitis, or TGCT, tenosynovial giant cell tumor. These drugs are used: imatinib, sunitinib, sorafenib, and nilotinib. DFSP responds very well to imatinib, and desmoid tumors to imatinib as well as sorafenib and pazopanib. So how do you practice and how do you approach your patient? This is the flowchart which will explain. First, a patient is diagnosed with a soft tissue sarcoma. The first question to be asked is it anthracycline sensitive histology? If it is yes, then whether it is angiosarcoma. If yes, taxane-based single agent or combination therapy may be used, or doxorubicin-based therapy is also effective. If it is not angiosarcoma, then depending on performance status, we can use either gemcitabine, and whether the doxorubicin is contraindicated, gemcitabine-based therapy or doxorubicin-based combination therapy or single agent therapy may be used. If the histology is not sensitive, anthracycline to sensitive, then PVNS, TGCT, or DFSP, imatinib, I've just mentioned, as per the type of the typical specific type of the tumor and the genetic makeup, the genetic mutations found out, we can use a particular drug. Thank you.
Thank you so much, sir. Thank you for the wonderful lecture. We'll move on to our debate now. The debate is going to be on role of adjuvant chemotherapy in soft tissue sarcoma, and the debater for and to give is Dr. Sujith Kumar, medical oncologist from Chennai, and who's against it, not to give, Dr. Prashanth Parameswaran NaiR, medical oncologist and hematologist from Calicut. So I invite the first debater, to Dr. Sujith Kumar, to please present his slides. Over to you, sir.
So you will have to unmute yourself.
Yeah. So the slides are visible.
Yes.
Yeah, so good afternoon and good evening to everyone. After the detailed discussion on soft tissue sarcomas, advanced cancers, options. Now we'll go to the very important topic of adjuvant chemotherapy in soft tissue sarcomas, basically. I'm sorry for the error. So I will be speaking for the motion that yes, we need to give adjuvant chemotherapy for soft tissue sarcomas, but yes, there are some conditions which will come to that. So no conflicts of interest. Yes, there are conflicts of evidence. We'll come to that. So why there is a talk about no adjuvant chemotherapy in soft tissue sarcomas? That is because of the EORTC 62931 study, which had randomized patients, around 351 patients, to observation versus adjuvant chemotherapy. The regimen was doxorubicin and ifosfamide, 5 gram per meter square, 24-hour infusion into 5 cycles. It was supported by linograstim, a GCSF agent. And the interim analysis showed no OS benefit, also at the end, the OS was sort of found to be detrimental in chemo, 64% versus 69% in observation. Later, there was a pooled analysis between the both EORTC trials. The previous EORTC trial had a regimen which did not have ifosfamide, and it was found that adjuvant chemotherapy was not prognostic factor for OS, and even the RFS was better only in the males and in more than 40 years. So the conclusion was the adjuvant chemotherapy is not indicated in soft tissue sarcomas. But there is some conflict in that. So as you see, ifosfamide is a very important agent in adjuvant chemotherapy. And the dose in EORTC 62931 for ifosfamide was only 5 gram over 24 hours, whereas the usual dose is around 9 grams. And also there was no ifosfamide in the previous EORTC trial. Also, chemotherapy was in 50% of the patients in the trial had grade 2 sarcomas, but we know in high grade sarcomas, chemotherapy has a better role. Also, to be very interestingly, 25% of patients in chemotherapy arm did not receive chemotherapy or started too late to be included. But as per the trial for intention to treat analysis, they were included in the analysis. The same, the Lancet Oncology paper regarding this study by Wall et al. They had done an update of actually an updated meta-analysis. In the same paper, they have mentioned that their data also is consistent with the previous studies, suggesting that patients with large, high-grade and extremity sarcomas are most likely to benefit from adjuvant chemotherapy. So as you can see in this forest plot, there is a trend towards adjuvant chemotherapy, even in their own paper where they had an updated meta-analysis. So now the latest data on the EORTC 62931 came in 2019, the European Journal of Cancer, where the authors actually went through the same trial in the extremity and trunk wall STS. In the same trial, they had using a nomogram circulator, I will come to that, they calculated the probability of overall survival, and they divided the patients into 3 categories, having high probability of OS, intermediate and low. So in the low probability of overall survival, that is less than 51%, they had this analysis. They found that adjuvant chemotherapy reduced the risk of recurrence by 50%, that is HR was 0.46, and death by a similar 50%. So in patients who had higher risk of death because of high grade features, they found that chemotherapy reduced the risk of recurrence and death. And they also, and to just confirm the results, they included less than 60% survival percentage. They again found that there was a significant disease-free survival and OS benefit when chemotherapy was used. So for the listeners, this is a prototype of a circulator. It's available in the net, where you can see different factors are added into, and we can calculate the risk of recurrence in the future. So this is the trial, or this is the meta-analysis that actually was proposed, was the reason that chemotherapy was being used in soft tissue sarcomas. This is an updated systematic meta-analysis of randomized control trials in soft tissue sarcomas. And the previous was in 1997, and this came in 2008. They had 1953 patients, 18 trials, and they found that survival was better when ifosfamide and doxorubicin was used. The odds ratio was 0.56. Both in case of local recurrence and distal recurrence, the odds ratio favored chemotherapy. And this is again a forest plot. As you can see, the type 1 chemotherapy is the chemotherapy which included doxorubicin alone, and type 2 is chemotherapy which had both ifosfamide and doxorubicin. So in type 2 type chemotherapy, they had a HR of 0.56. So again, it is showing the results in favor to receiving chemotherapy. What are the other evidence we have? So as we all know, adjuvant chemotherapy mostly is beneficial in case of distant control. So we had a study in clinical sarcoma research where it was actually a retrospective chart review, that they had 273 patients who had, out of which only 24% received chemotherapy. So they had two groups which had received chemotherapy and not received. They found that in high-grade disease, 5-year benefit in distant control was 68% versus 54%, especially when patients have received the mesna, adriamycin, and ifosfamide-based regimens, where it was 74.2% when compared to 54.2%. So that is around 20% benefit in distant control. Also, the benefit of chemotherapy was more pronounced in this regimen when compared to other regimens. So again, this is an evidence that we have chemotherapy definitely improves distant control in localized high-grade soft tissue sarcomas. Now, this is a very large study, basically based on the National Cancer Database, 5,436 patients, and most common 5 subtypes of STS were analyzed. They found that there is no difference in the timing, neo-adjuvant versus adjuvant, but the multi-agent chemotherapy was associated with improved OS in several subgroups. And even in elderly patients more than 70 and African-American patients, they found that the improved survival was mostly in tumors more than 5 centimeters, those who have received radiation and those who received care at high volume centers. Many times we do emphasis on that fact that sarcoma should be managed in high volume centers. It might be related to the adequacy of surgery, the benefit of radiation, also because the chemotherapy many times is intense, and the management of toxicity is a very important part of that. So coming to the guidelines, NCCN, yes, it is. It says that in stage 2 and stage 3, adjuvant radiation, adjuvant chemotherapy is advisable. Doxorubicin with mesna and ifosfamide or epirubicin. ESMO says to consider anthracycline and ifosfamide-based adjuvant chemotherapy in patient at high risk for death. And the National Cancer Grid from India says in patients who have more than 5 centimeter tumor, high grade, recurrent, to consider doxorubicin ifosfamide-based adjuvant chemotherapy.
Sir, half a minute left, sir. Requested you continue.
Yeah. So we had a survey regarding the practice of adjuvant chemotherapy in STS. So we found that majority, 96.5% of the oncologists gave chemotherapy in soft tissue sarcomas. These were the high risk features: high grade, size more than 5 centimeter, deep plane and extremity. And most of them felt that histology is an important part in deciding adjuvant chemotherapy. We know there are good chemotherapy sensitive histologies like synovial sarcomas, leiomyosarcomas, and undifferentiated pleomorphic sarcomas. And the regimen of choice was ifosfamide 9 gram per meter square over 3 to 5 days and doxorubicin. And this was again a survey that we did in Twitter. Again, 70% or 85% of the patients felt that adjuvant chemotherapy is required for sarcomas. So I would say I am for the motion that adjuvant chemotherapy is indicated, especially if there is high risk features, high grade tumor more than 5 centimeter, deep to deep fascia and extremity, especially in chemosensitive sarcomas like synovial sarcoma, undifferentiated pleomorphic sarcoma, mix of fibrosarcoma, myxoid liposarcoma, and leiomyosarcoma. Prognostic nomograms like sarculator may be useful. I don't think in near future we have adjuvant setting immunotherapy or targeted therapy coming into role in soft tissue sarcomas. Thank you.
Thank you so much, sir. I now hand the mic to Dr. Prashanth. Over to you, sir.
Thank you, Sujith. Am I audible?
Yes.
Yes, sir, you're audible, sir.
All right. Being a medical oncologist, speaking against chemo has been a painful thing, but you should know when not to give chemo. So I think it's not so clear forward. The thing is that basically it's a heterogeneous group of disorders and there is no correct, well-controlled randomized clinical trial. So the proper RCT requires at least 10 years for accrual for a sarcoma. And if you look at the incidence, 50% only happens in the extremity. So our debate is going to be this 50% of people. And this is the outcome from MSKCC. And that you understand that the outcome of sarcoma is still around 60%. So we think that by addition of chemo, can you improve the outcome in this group of patients? So for an adjuvant chemo, according to me, should improve the overall survival. At least that should be the main guideline which we have to be followed. And so we have told this risk factor like location, grade, large primary, deep location, aggressive histology. But what has been the basis for this, for making this as a risk factor? Majority of the time, it's a hypothesis generating, I feel. So some positive trials which have shown, and I'll tell you the caveats of this. This is the first generation 14 trials, out of which 2 were positive and 3 were negative. And this was that SMAC meta-analysis which came. And SMAC meta-analysis in 1997 showed there is no overall survival benefit. But there is a caveat for this. They told that ifosfamide was not used. All grades were included. But whatever it is, there is no OS advantage with an adriamycin with a proper dose. So point taken. But they told that extremity did better. But I'm telling you, it was a subgroup analysis. There was nothing called an extremity people was given and not given and all other people were given. So you can't do a subgroup analysis. An initial trial should plan a subgroup analysis. It's a meta-analysis. You can't do a subgroup and tell that extremity did better. And the criticism was only anthracycline single agent was used. Then the SMAC modified trial came, this 1,953 patients, which used ifosfamide and adriamycin. Only 4 trials was added in this, and the broad range of ifos and adria was used. It's not on 9 grams, 5 to 9 grams were used in this. The main thing which I felt about the SMAC meta-analysis, which showed an OS benefit, is that the improvement in surgical procedures were happening at that years. The landmark paper for wide local excision came. And if you look at the control group of 1998 SMAC and 2008 SMAC, there was 10% benefit in the control arm. So jump in OS is better more for the local therapy which has happened, and more of radiation has been given and cannot be attributed full for chemo, which is what I feel in this SMAC meta-analysis. Then there are 2 French trials, and this French trial showed that grade 2 patients didn't have any benefit. Grade 3, they showed benefit. And that was also a subgroup which they did later. And this was very interesting, the Italian trial. Benefit for adjuvant ifos adria, but after 1 year or 2 years, they published their long-term survival, and they showed that there is no survival. So that means time of follow-up of your study is important. Short-term follow-up in recent trial has shown a benefit of chemo, which happen only in following some first year, and after that, it starts waning by 3rd year. So that is what it has shown. So the long-term benefit is not happening. If you look at the negative trials, there are Austrian, Italian, and that Wall et al, which EOTC was telling. That other EOTC first trial didn't have ifosfamide, but had cyclophosphamide. It's an alkylating agent, but I agree that it was not ifosfamide. But this was the second EOTC trial where ifos adria was used. But it showed that adjuvant chemo is not associated with better overall survival, and it is the largest randomized control trial which has been happened. I agree there has been an update which has happened, but they have told trend for this thing, but still the overall survival is not adequate. So trend and overall survival is entirely different. And they told that we should have chemotherapy should be considered as an investigational procedure. Now, if you look at the response of chemo, ifos should be around 9 to 10 grams. I don't know how many of us will be using 9 to 10 grams, but still, if you want a response, ifos adria, ifos should be around 9 to 10 grams. Then only you will get a 79% of objective response rate. Then there are trials which have adjusted 14 days of ifos adria. If you're telling ifos is the most magic drug, and this has not shown any beneficial. Even the MSKCC and MD Anderson, they have tried in 50% of their group, and they've showed that same OS and relapse rate in both arms. And most important is, if you're giving a chemo or if you're giving a treatment without a survival benefit, you should think of the issues with chemo. That means a short-term toxicity and extensive supportive care for 9 grams per meter squared of ifos is separate. Other than that, young patients, sterility, cardiomyopathy, renal dysfunction, second malignancy, and quality of life. And this one graph, which I want to tell that those who have received anthracycline and not received anthracycline, in this pediatric sarcomas, the tendency of mortality or the chance of death is more early in this group of patients who has received chemo. So you should be very much justified in giving your chemo. So is histology-based answer chemo the answer? No, it's not the answer, because that has been shown in trial that it is negative. It's not going to be superior to anthracycline. Neo-adjuvant chemo is coming. Multi-center proper conducted randomized control trial is the future. And there is something called the SINSARC or complexity index in sarcoma, which helps prone for failures and will benefit from chemotherapy. We don't know that. So my take home is adjuvant chemo for soft tissue sarcoma remains an investigational procedure and cannot be routinely recommended for high-grade soft tissue sarcomas. Multidisciplinary sarcoma tumor board is must. Adjuvant chemotherapy cannot rescue for an inadequate initial surgery, and the most effective effect of chemo in EOTC was in bad surgical arm. Every study of adult soft tissue sarcoma has heterogeneous people, and level of heterogeneity is very high. And all the criteria which you are used telling, which is called the grade, the size, extremity, everything is hypothesis generating. So I'll stop with these 2 case scenarios. I'll ask the answer from Sujith itself in rebuttal. In last 1 month, I have seen these 2 patients. I was thinking who was having difficult patients of sarcoma. First is a 28-year-old man, unmarried male, 3 into 3 centimeter high-grade synovial sarcoma in scapula, post R0 resection. What will you give? And second is a 40-year-old male who has a 10 centimeter lesion in right thigh with grade 2 spindle cell sarcoma. We did a maximum IHCs, all came negative, post wide local excision R0. I'll stop here. Thank you.
Sujith sir, over to you for the rebuttal. So you'll have to unmute your mic, sir.
No, I agree. There was very nice points that Dr. Prashanth has raised. But again, the same thing that we have discussed, the STS is not a single entity, it is a multiple types of entity with different histologies. So I'm not convinced with Dr. Prashanth's concern about the toxicities. We do give much toxic treatment in having sarcomas, and we are able to manage them. We have long-term results from OGS 2012 where we have much higher dose of ifosfamide being used, and the rates of sterility are not that high. So I don't think the toxicity should be a concern when we really want to bring in a change in the survival. I still feel that the EOTC trial, which was the negative trial, had a lot of heterogeneous things. I have already mentioned them regarding the chemotherapy and the dose of ifosfamide, and I think that trial was not properly done. I don't know whether we will have a multicentric large trial like that again, because there is nothing new which will be tried. It would be again the chemotherapy. We don't have any new agent. Coming to the two scenarios that Dr. Prashanth has mentioned, 3 by 3 centimeter tumor in synovial sarcoma, complete resection, 28-year-old male. Yes, both the case scenarios, especially in the patient who had a high-grade synovial sarcoma, I would definitely discuss the option of adjuvant chemotherapy with the patient and giving him the chances that there is definitely a high risk for him to develop a distant. You see, in a soft tissue sarcoma, even if they are localized, especially in extremities and trunk, there is 40% of them to progress over a period of time with distant metastasis. So definitely, even after the well-done surgery, I feel we need to discuss the option of adjuvant chemotherapy. Yes, as I know why you are unmarried and 28-year-old. Yes, we have issue of sterility. We have options for semen preservation, etc., which we can be considered if and when the patient is fine, we can do that. So I don't think that is a reason of not offering now for the next patient 10 centimeter grade 2. Again, as per the high grade and
apologies, sir, we're running short of time. Sir.
Yeah. So I think we should be discussing with both the patients regarding the benefit and the risk, and the decision should be a shared decision making between the patient and the oncologist.
Thank you, sir. Over to Prashanth, sir, for the rebuttal.
Point taken, Sujith. So that is what I told. That means it is basically the shared decision making between a clinician and the patient is going to be the answer. There is no clear-cut evidence to tell that there is level 1 to tell you have to give. But as a medical oncologist, we want the best for the patients. So I
want to ask you, will you not offer? I want to ask you, will you not offer?
I do offer. Okay. Debate was different, but in the practice, I do offer. I agree with that.
Yes.
Yeah. Thank you, Kashish. I'll stop here.
Thank you so
Thanks
much
for the opportunity.
Thank you so much, Sujith sir. Thank you so much, Prashanth sir.
Thank you.
We'll now move on to the panel discussion. It gives me great pleasure to introduce our moderator, Dr. T P Sahoo, who is a senior medical oncologist from Bhopal, and his panel will be on therapeutic armamentarium from NET to NEC, all you need to know. And his panelists are Dr. Chandra Mauleshwari, pathologist from Chennai, Dr. Sanju Sairak, medical and hemato-oncologist from Kochi, Dr. Purnima Kishore, oncopathologist from Bangalore, Dr. Bhavesh Parikh, medical oncologist from Ahmedabad, Dr. Jovita Martin Daniel, medical oncologist from Chennai, Dr. Vijaya Viran, radiation oncologist from Salem, and of course, Dr. Sachin Hingmere, medical oncologist from Pune. Over to you, sir.
Yeah, and Kashish, all of them are there, no?
Sir, Dr. Sanju is not there, and Dr. Vijay will join us soon. He's driving, sir. The rest of them are there, sir.
No problem. Just let me know.
Sure, sir.
Okay. So Dr. Sanju is not there, and Dr. Vijay will join. Okay.
Sure, sir.
Okay. So stop share. My screen is not full screen till now.
Not yet, sir.
Okay. Can you share it from your side, please?
Sure, sir. We'll just share this slide.
Is there now? Just see, yeah.
Yes, it's full screen, sir. You can go ahead.
Yeah. Thank you. So thank you, organizers. Thank you, and let us now in the next 25 minutes, what's given to us, try to make the best out of it. It's a huge topic in itself, so we have to go from the neuroendocrine tumors to the carcinoma thing, and it's a large basket which you need to cover. So let's go to the salient points. I'm sorry I have missed Dr. Chandra's name, and I'm sorry for that. So I will be including him in the discussion. So, yeah. Shit. The slide is, yeah, it's there. Okay. So now we have a 53-year-old male who's presented with the history of cramps and crampy abdominal pain, and it is on and off for last 5 months. The ultrasound showed some liver metastasis, and the biopsy was a grade 2 neuroendocrine neoplasms. So I would first like to, the mitotic figures were 6 in the 10 high power field. So first to Dr. Chandra and Dr. Purnima, how frequently would you look into how frequently do you find a neuroendocrine tumor? And would you also tell us how do you differentiate between a neuroendocrine differentiation and a neuroendocrine neoplasm per se? These are 2 points which I wanted the pathologist to come in. And the third point after that, I think Dr. Purnima can take in what has been the differences between the 2010 and the latest WHO classification.
Yes, sir. So this is Dr. Chandramouleshwari, sir. Good evening to all of you here. So I think the first question is with regards to the mitotic activity, or do you want me to answer about the neuroendocrine differentiation first?
Yeah, so in a very quickly, in maybe 10 to 20 seconds, how would we, as the medical oncology, we see a lot of the reports with particular carcinoma with neuroendocrine differentiation versus a neuroendocrine neoplasm? Just a salient 1 or 2 lines of this.
Okay. So it is a neuroendocrine carcinoma with neuroendocrine differentiation would be any carcinoma. For example, it could be an adenocarcinoma, which can show neuroendocrine differentiation at focal areas, which can be demonstrated either by morphology or by immunohistochemistry. Whereas a neuroendocrine neoplasm as such, it is pure and simple neuroendocrine tumor as such. It is not even called as a neuroendocrine neoplasm anymore. It is called as a neuroendocrine tumor, wherein it is graded into grade 1, 2, and 3 based on the Ki-67 index and the number of mitotic figures we see, preferably the Ki-67 index and not the mitotic figures anymore as regards to the 2020 classification of WHO.
Okay. So Dr. Purnima, can you come in? And this is the latest, I think WHO 2019 is what my previous panelists just spoke. Because we listened to this Ki-67 story, which is a very difficult job in the breast cancer scenario. And the only thing that comes in the panel discussion is the Ki-67 thing validated. Are we very sure of the Ki-67 index? And when I see this classification, it's purely on the mitotic count and the Ki-67. So how confident are we as the medical oncologist when we get a Ki-67 report? Do you think that reports of Ki-67 is validated enough for us to believe when the pathologist gives us the report? Or do you feel we are still on the learning curve of it?
Just to inform you, Dr. Vijay and Dr. Sanju have also logged in, sir.
Okay, thank you. Dr. Purnima.
Yes, sir. So ideally, we're supposed to count in the most hot spot about 500 to 2000 cells. Then it is valid. But if you're looking at small biopsies, to count about 500 cells to 2000 cells, that is not possible at all times.
Okay.
So valid is subjective.
So you feel still the pathologists depend upon the mitotic count to give us the G1, G2, G3, NET and the NEC?
We do count mitotic figures, and we also do a Ki-67 index, but we go more with the mitotic count, and we go more with the mitotic count.
Okay. So basically the point which I wanted to highlight has been very, very clear. The classification points out these 2 things. Even you find literatures, even thinking of taking treatment to a different levels based on the Ki-67. If you look at there's data that beyond 55 Ki-67, the treatment is quite different for a grade 3 NET, and less than 55 it's different. But there are still issues with the Ki-67, and still most of the reportings does, although I have a Ki-67, we also want to look at the mitotic counts. And definitely the difference between the G3 neuroendocrine tumor and NEC is the poorly differentiation versus well differentiated. So with that,
I would like to add that it is not solely Ki-67 or mitotic count. There is also enough weightage given to the morphology and added features like necrosis. And there should be, if you see in NEC, compared to a WT, a well differentiated NET versus a poorly differentiated NEC. there will be certain points such as necrosis, frequent mitotic figures, and frequent apoptotic bodies.
Yeah, agreed. And that is well pointed out in the classification that the difference specifically for the G3 neuroendocrine tumor and NSC is the well differentiation versus the poorly differentiated in the neuroendocrine carcinomas. Point well taken. So now we move on to the our medical oncologist fraternity. Now with this, let's come down to Dr. Jovita. So now will you tell me how would you proceed with this? Very quick, short answers.
Sir, first I would like to know the exact site, whether it is a small intestine, pancreas.
So what would you do? This is a case which has come down to the OPD with the biopsy done, and this is what it is. It is we have a grade 2 neuroendocrine tumor.
All right. So we would also like to know if the patient is symptomatic, as in whether the carcinoid symptoms are present. We'll have to check for the staging needs to be done, and also the somatostatin uptake.
So I made things easy for you. Which one would you pick up?
I would go for a PET DOTA scan, gallium 68.
Okay, so you want to do a PET DOTA CT scan or PET DOTA MR?
PET DOTA MR is better, sir, when it comes to liver also being involved, and if it's to exclude the extra-abdominal organs and things like that. I think the details will be better.
Okay, so Dr. Bhavesh,
we go for a scintigraphy.
Okay, Dr. Bhavesh, practicality. Not everywhere you're going to get a dotated PET MR or PET CT. What we just do on CT scan and a contrast enhanced CT scan? Is it fair enough, or are we going to miss something? And sometimes it is necessary for us to refer it to our centers.
No, I think for practicality in tier 2 city, as you rightly explained, that DOTA might be even in the higher center also. Sometimes the molecule procuring, the nuclear medicine specialist told us that, sir, today we does not have a DOTA molecule or the somatostatin receptor. So I think CT scan, abdomen and thorax, plain and contrast will also suffice, because we had know that it is a liver metastasis, and we know that it is a neuroendocrine carcinoma grade 2. So I think if in non-availability of such type of things in tier 2 cities, definitely CT scan, abdomen and thorax will suffice.
Yeah, so the appropriate is what Dr. Jovita told, and that would be the best way to do it. And the dotate based PET scan, PET CT or PET MRI would be very much sensitive than even a skinty. And I think most of us do CT scan with IV contrast, and that's where it is. But definitely you might miss those small primaries. And it was pointed out that we definitely want to look at this as a secreting tumor or a non-secreting. So, Dr. Sachin, chromogranin A, should we be doing it today, or should we abandon this chromogranin A thing?
So basically, chromogranin A as a diagnostic value is obviously not there. There's no role of chromogranin A as a diagnostic because of poor sensitivity, as well as few instances of high or false positivity. So not as a diagnostic. Obviously, we will not be able to depend on chromogranin A for diagnosis. Chromogranin A may be useful, especially in metastatic setting, as a prognostic value, because chromogranin A values will be higher in patients who have a higher tumor burden, and that may be useful in few patients where we want to monitor response to treatment. But then my dependency or
point taken. Dr. Vijay, can you take this? Do you agree with Dr. Sachin, or you have a different point of view? Okay, Dr. Sanju, can you take this?
Definitely, I'll be doing a chromogranin A for all patients at baseline, so that I can use some blood test, blood marker for monitoring progress of all patients with a neuroendocrine tumor.
So I want to point a very clear thing. We all have been doing this, but into latest NCCN has taken out this specifically. I agree with Sachin. It's a very low specificity and sensitivity. Both ways, it is touching to a tune of 50 to 60%. And that there are some reports initially the specificity to be high, but most of the reports now is that it is not of value for diagnosis, and that's where it stays. That's why it has been taken away actually. from the diagnostic criteria, and we should be avoiding it for diagnosis. That's the point. Anyone in the panel wants to take this, or anyone has experience on the NETS test views? Anyone? Quickly, and then we move on. Bhavesh bhai?
No, I'm not.
Okay, so this is something that is picking up. It has no phase 3 data actually. It is more of the mRNA circulating tumor cells and more of the informatics things. It is by a Clifton Life Sciences. It is, if you see the data, it's gradually evolving, but you don't have a phase 3 data to bind upon it that it is mandatory for a diagnostic test. But you will see more of this. So I thought to bring in this. So we did the PET MR with the rotate, and it was a jejunal primary with bilateral liver involvement. And correlating with the symptoms in the biochemical, it was a non-functioning neuroendocrine tumor. So now with this, what next, Dr. Jovita? What would you do? Would you think, would you operate this case? Would you consider a patient to be referred to a surgeon? Quick, yes, no.
Sir, yes, sir, I would, because if he's symptomatic, then I need to give him the relief. We have to have a surgery.
So he had mild to moderate crampy pains, and that will be indication for you to send it for surgery?
If it's resectable and if it's feasible, yes, sir.
Okay, if it is not resectable?
Then we could watch and wait and watch.
Okay, Dr. Sachin, what are your indications to send a patient for surgery? Yes, total resection, take that out.
So apart from those who have resectable primary and resectable metastasis, if we leave this indication apart, one thing is, if any site is highly symptomatic, whether it's primary or it is metastatic. So a symptomatic tumor site, which is where the shrinkage of the tumor will give the patient symptomatic relief, then obviously if the site has to be resectable, then I would think of surgical as an option. Okay. The second indication would be obviously patients who have very high carcinoid symptoms, which are not managed with our octreotide.
Okay. So I think Sachin has made some valid points. We definitely, a total resection, as Dr. Jovita also told, is an indication where we should refer it to our surgical colleagues. But if the patient is highly symptomatic for a particular bulky disease, and if it can be resected to around 90% and it can relieve the symptom, it could be an indication. There are data that if there is a symptomatic secreting tumors and it is not controlled by supportive care or medications, that also could be indication. Now we come down to more of the medical oncology issues. Dr. Vijaya, you're there?
Can I just
please
ask a question here? What the panelists think about resection of primary tumor as a way to improve the survival? This is what I have brought out because of the PROMET study. In the PROMET study, patients who had a resected primary had a bit better hazard ratio as compared to who did not have.
I think, Sachin, your last word tells it all. It was PROMET study was a small study. It had a different criteria and wanted to assess something very different. We will come to that. But I don't think I would make a conclusion out of it that if there's a metastatic disease, that it is not symptomatic, and you resect the primary and then it does benefit the survival. I don't think there is a very good level 1 data. And to go for surgery for that as an indication, I don't think that we have that level of evidence. And no guidelines actually do that. We have, when PROMET is a very small study, and if it's not looking at that particular thing, I would not look into that and try to change my practice as per that. So I think the others can put in the chat what they think about Sachin's suggestion. So I would like to now come down to Dr. Bhavesh. What is your medical treatment of choice? You, then Dr. Vijaya, please.
This is non-functioning grade 2 jejunal
neuroendocrine tumor with liver metastasis and not deemed feasible for surgery.
I will go for octreotide.
Single agent, octreotide, and what dose?
30 milligram.
30 milligrams. Dr. Vijaya, you're there? Okay. So, Dr. Sanju, I would like to go for a PRRT therapy, dotate, and a combination with octreotide. Am I valid enough to do that?
Yeah, there are a lot of data to suggest that upfront PRRT is a very good option for these patients, but I don't think the acceptance is that much among the clinicians we all keep it for a later use, either in the second line or third line or beyond. But I think there are data coming up which shows good benefit for that strategy. But as Dr. Bhavesh told, I will also go for octreotide 30 milligram as the beginning of, the start of treatment.
Dr. Sachin, dual therapy, okay, or you want to still preserve the dotate therapy for the later points?
No, I think in our case, in this particular case, we may go for a dual therapy. 2-3 reasons for that. First is we are into intermediate grade. So whatever data is available for a single agent SSAs is selectively for very low grade tumors. Both in PROMED and both for the lanreotide study, they had a very low grade tumors. So one thing is we are extrapolating data from low grade tumors where we are dealing with a kind of an intermediate grade tumor. Second thing is our single agent SSAs will stabilize the disease, but the response rates will be very, very minimal. And in our case, because the patient is symptomatic, because of his pain, shrinkage of tumor is equally important. So adding PRRT will give some additional response rate benefit. And that may be the reason I would think
Okay, that's fine. For point taken, and I'll come down to that point. Bhavesh, you are muted. You wanted to say something. Yeah, please.
Sachin, my point here is that most important, as you rightly told, whether we had done surgery in this case or not. If we had done the surgery and then the question of Sahoo, whether we are going for octreotide. And your question is the tumor burden. Rather than tumor burden, even the means how much liver metastasis, and especially if from somatostatin receptor scan, DOTA scan, if we know the tumor burden, then again this therapy will be more considered.
I'll come down to what Sachin is saying, and he has a valid point in that. I'll come down to that, although it's not a standard of care, but this is definitely evidence is there what he's telling. Anyone, Dr. Jovita, for liver directed therapy, you would like to do some liver directed, maybe a local liver directed therapy, or would you just wait for systemic and then take it later on when it comes through?
Sir, as per what you had actually mentioned, PRRT would be a very good option. But in case, the patient is not affordable, or, we have, this liver lesions being the main problem, then yes, obviously RFA can be offered to the patient.
Okay. So liver directed therapy is something which you can always offer at any point of a treatment, depending upon the symptom size and the availability of the things. Coming down to PROMED, as I told, it's a very small trial. It just told you that the PFS was superior 14 versus 6 months to the use of the octreotide LAR. The OS was not there, and you would not find OS benefit actually in anything actually. And you have data actually telling that 10, 20, and 30, all the doses of octreotide actually do equally good. The flushing was little more well controlled with the higher dose. The lanreotide, Dr. Sachin, just to tell you that this data had taken key 6-7 till 10%. So they did take intermediate. So they're telling that the data is not there for using octreotide like analogs. Is something which I think there is data to that aspect. The grade 1, grade 2. Yeah, please.
So mitotic count was not taken into consideration. They had specifically on the Ki67. In our case, we don't have.
If you look in the text of the NEGM, they looked into both. They took mitotic and the Ki, but they took till 10%, while the PROMED had only till 1%, 2%, till 2%. So fair enough, but you could use in both the things. Again, the same thing, the PFS was there, but the OS benefit was not there. Has anyone known of this drug called Telorgestrat? This is a drug which is approved in 2017 for carcinoid syndromes, not controlled. And this is not available to my knowledge in India, but the 250 or 500 milligram twice a daily dose is there. And we should be considering this if someone has a carcinoid syndrome, not controlled. Now, coming down this, Sachin, this is where Sachin told the NITR one. The NITR one, if you look at it, it was a combination of the dotatate plus octreotide versus octreotide. And if you see that the curves do separate, and there was a benefit for PFS. This data was not so significant for survival, but still there was 11 months difference in survival for the combination. So Sachin's point is taken, that all the data that has come out in the neuroendocrine tumors have been on the PFS data. So why differentiate between this data? Because this also has a significant PFS, and also the OS, although non-significant, was 11 months difference. So if there's a symptomatic, rich pocket patient where you want to do a response because the response is around 20 to 30%. So Sachin, you have a point. This could be one of the options where you could consider in the front line, but this drug is also active in the third line also if you have failed first and second line. That's the only 2-3 points I want to make. And Sachin, you had a point when you went for combination. So this patient went for bowel resection with cholecystectomy, started on octreotide, imaging done once every 4 months. And after for 1 year or so, there was increase in size, but patient was essentially asymptomatic. Dr. Bhavesh, would you do something or wait and watch and wait for the patient to get symptomatic to change your treatment? Quick yes, no.
Wait and watch.
Wait and watch. Anyone wants to change? Dr. Jovita, Dr. Sanju?
Symptomatic, I think RFA can be given, sir.
Okay. So it is fair. I told you that liver-directed therapy can be given at any point as per the situation as it evolves. But you also have the option of wait and watch if the patient is asymptomatic. But you also could change. There's nothing much level 1 about it. But yes, if you wait and watch for asymptomatic, it does not matter much on survival. That's also a point which I wanted to make. So we continued on octreotide. And the second line, anyone has second line choices? Quickly, we'll move on to the last slide. Maybe everolimus or combination of octreotide and everolimus. Dr. Sachin, what is your choice?
So patient, I would go for PRRT.
Okay. So if the patient has not received it, your second line will be PRRT.
Yes. Provided the DOTA scan still shows the receptor
uptake. It does show its uptake. That's what you meant.
Are you happy with PRRT with octreotide 30 milligram or only PRRT now? If PRRT was not given previously?
With that NETR trial, I'll go for combination.
Yeah, that is the
NETR trial 1 was a first upfront thing, but there is also data which tells you that people are skeptical about combining octreotide with the DOTAT, but there is data that you might combine. It does not affect much. The only thing is you should be giving octreotide maybe 1 to 1.5 hours before the DOTAT, and could give the octreotide 24 hours after the DOTAT is given. So that is one thing that we probably need to know, and that could be the interval of doing it. And there is no hard first rule, but most of the data is that combination does matter, and continuation of octreotide LR, even with everolimus, has shown activity. So I think if the DOTAT is not there for the PRRT therapies, Bhavesh bhai, is it everolimus for you or is it Sutent for you?
Everolimus.
Sir, 2 minutes left, sir.
Yeah, I'll come. So there is the option of going for single agent everolimus. There's also option for going for a octreotide LAR with everolimus. And this data comes from multiple trials, and there are at least 4 of these trials across Radiant 1, Radiant 2, Radiant 3, and Radiant 4. I'm not going to details of it, but there are 4 trials across subsite, 2 in pancreatic entities, 2 in non-pancreatic entities, and this does show that everolimus is an active agent. Even sunitinib is an active agent. So now, we added everolimus and octreotide, dose reduced due to toxicity. Patient was symptomatic, developed 3 new liver mets. Because we have not done the DOTAT, we just did the DOTAT at this point. So now we'll switch gears and we will just go for single lines. Dr. Jovita, approach for a grade 3 NET. Not Jovita, Dr. Sanju. How would you approach a grade 3 NET advanced metastatic? What is your drug of choice?
Chemotherapy.
Dr. Sanju? Okay. So, Dr. Bhavesh, what is your chemotherapy of choice or what is the agent of choice?
Carboito.
Carboito. Dr. Jovita?
Yes, sir. I will go the same.
Sachin?
In this case, Ki67 may play some role. If Ki67 is more than 55, that has been brought out from some retrospective study. If it is 55, etocarbo less than 55, then temozolomide, capecitabine, bevacizumab, all these drugs will be of equally efficacy.
The most consensus regimen is capecitabine and temozolomide for a neuroendocrine tumor grade 3, and the best data has come from that. We could go for capecitabine single agent. The EP, the etoposide and cisplatin data is there, but normally the responses are okay, but it is normally short-lived. Even I do practice etoposide cisplatin, but the data is strongest with the capecitabine and temozolomide. But there are multiple options of capecitabine, temozolomide. Even Folfox has played quite a good regimen. Even that is the most common regimen. People use it in second line. And if you look at it, for the capecitabine and temozolomide, look at the first line and second line. The responses just are so less in second line. That's why it is a drug of choice for anyone with NET grade 3 to have a cap and temozolomide as a first line agent. So now, NEC, neuroendocrine carcinoma, I don't think there's much of difference. We just go for cisplatin and carboplatin and etoposide, but a cap temozolomide is also there. So my take-home message. Anyone wants to tell something here? No?
Right.
Okay. So take-home message is resection. Complete resection is the standard of care if it can be done. Subtotal, usual in symptomatic cases. For surgical liver directed therapy, gold standard is surgery. If not operable, at least 90% surgery should be done so the load is less. Ablation for smaller tumors, as Dr. Jovita told. Chemoembolization, hepatic artery embolization, radioembolization are options. Medical management to control hormone excess like carcinoid. You have drugs like telorestrat, although not available, is a very good approved drug. Alleviate symptoms is the main thing because none of the agents have shown a survival benefit. The best agents, probably the patient symptomatic, has a deep pocket and his uptake on dotate is there to do the dotate therapy and the octreotide together. But you still could go for octreotide first line and then go for dotate in later lines. For the carcinomas and the neuroendocrine tumor grade 3, capecitabine temozolomide stands the drug of choice. The maximum load of evidence is with this combination, although most of us practice a platinum and a etoposide. So with that, I stop. Thank you, organizers, for giving me the opportunity, and sorry for jumping by 1 or 2 minutes.
Thank you, Sahoo sir, and thank you to all the panelists. We'll move on to the next debate. Our debate topic is Neo-adjuvant versus Adjuvant Radiotherapy for soft tissue sarcoma in clinical practice. Our first moderator who's going to talk for Neo-adjuvant Radiotherapy is Dr. Anand Narayan C. And for our second debater is Dr. Madhu Sairam R, who's going to talk for Adjuvant Radiotherapy. So with that, I'll hand over the mic to the first debater, Neo-adjuvant, Dr. Anand Narayan C. Over to you, sir.
So, can I share my screen now?
Yes, sir. Please go ahead, sir.
Is it on?
Yes, sir. It's visible. Please
go
ahead.
Okay. Right. Good evening, everyone. So the next topic will be on sequencing of radiation in a soft tissue sarcoma. So I will be talking for the motion that neoadjuvant radiation should be the standard of care in any soft tissue sarcomas. My slide is not moving.
So you can use the arrow keys.
Yeah. 1 second. Yeah. Okay. So what will we be dealing with is extremity sarcomas, that is resectable stage 2-3 sarcomas and truncal wall sarcomas. What we will not be dealing with is erythroperitoneal sarcoma, rhabdomyosarcoma, Ewing's peanut, and GIST, because these are all special entities and they have a very different management algorithms. And we have been talking since the start of this program that it is a rare cancer and there are multiple histologies. Each histologies have a different natural history. Their behavior to treatment is different and their outcomes are different. But until recently, they have always been clubbed together and studied as a single entity. And even now, all the local therapies for all these sarcomas are studied as a single entity. This is the NCCN screenshot, which shows that there is a category 1 recommendation for both preoperative and postoperative RT. And what we already know is that RT needs to be given at some point because it's very clearly documented in the literature that it avoids radical surgery like amputation as well as and also it improves the local control based on studies. What we also know is that the local control and overall survival are similar if we give radiation before or after surgery in a randomized setting. That is, the data comes from a Canadian NCI trial, which we'll be dealing later. So the debate happens because, with a similar local control and a similar survival, there is a difference in toxicity. The preoperative RT results in more acute wound complications, nearly double what will happen with the postoperative RT. But the postoperative RT results in more long-term complications like fibrosis, joint stiffness, edema, and bone fracture. But we have to understand that this data, where these percentages are given, is about 2 decades old. So after that, there have been attempts to improve control rates with preoperative radiation and also improve the toxicity profile. We'll see one by one. So this is the data on improving local control. This is a real world data, around 800 patients. We can see that the preoperative RT was not only associated with a better local control, but also associated with a better cancer specific mortality and overall survival. There are multiple hypotheses why this happened, and the one thing is the preoperative RT resulted in better sterilization of microscopic disease at the edge of the tumor. Let's not go into that. And we all know there absolutely no debate that surgery with adequate margin is the key in management of soft tissue sarcomas, and any R plus resection will result in worse local regional control even with additional RT. So we can see from the same NCCN screenshot what emphasis has been given for the surgery. The surgery is written as surgery to obtain oncologically appropriate margins. So does Neo-adjuvant RT help with that? Yes, Neo-adjuvant RT, this is a data, again, a real world data on around 30,000, 27,000 patients. Half of them received RT, around 12% of them received preoperative RT, around 38% received postoperative RT. If you go to the demographic data, the patients in the preoperative arm had larger tumor size. In spite of that, if you see the R0 resection was operative arm compared to 75% in the postoperative arm. And the curve to the right also shows that the survival improves with R0 resection. So definitely the preoperative RT helps with the resection of the tumor. And does it improve toxicity profile? Yes, there have been, this is the randomized control trial, the original trial I showed you, the Canadian trial, which was published way back in 2002. This used a conventional radiation. This is the older generation radiation, as well as wound management that was 2 decades old. So even with that data, if you see the red box, those tumors which were located in the upper arm or the upper limb did not have any difference in the wound complications. So just by selecting the site, the upper limb site, your preoperative RT is not going to cause the wound complication, acute complications, which we are debating on. And what about the late toxicity? Obviously, with improved RT, there have been 2 phase 2 trials, one RTOG trial and one Canadian trial, which has shown that the use of intensity modulated radiotherapy or image guided radiotherapy is going to reduce your late toxicity and improve your long-term functions. So in short, for the patient, it provides a better long-term toxicity, provides a better long-term function, and it also has a shorter treatment because your preoperative treatment is of 5 weeks rather than 6 weeks, which we usually give in postoperative setting. For the surgeon, it will help in better resection because it forms a the tumor forms a pseudocapsule, helps in better resection, more R0s, as we have seen from the previous real-world data, and potentially reduced tumor seeding during surgery, which results in lesser distant failure. And for the radiation oncologist, we can treat better if we can see better. So when a preoperative setting, we can localize the target better, and we will use lesser dose and lesser volume because the dose is lesser and the volume is lesser because we don't need to irradiate the operative areas. And there is always a potential for hypofractionation. This is coming up, and with hypofractionation, we might be able to reduce the treatment time even lesser, resulting in better compliance. So this is the recommendation 2021 recommendation from American Society of Radiation Oncology. I would like to divert your attention to the right side of the chart, which shows that if RT is needed, any tumor with high risk feature where RT is needed, the recommended treatment is a preoperative RT, and postoperative radiotherapy should be considered as an alternative. So this is a strong recommendation with a moderate evidence availability. So let's not dwell in the past because the RT techniques have improved, the wound management have improved, and there is always a potential to combine with systemic therapy. So all patients before sarcoma surgery should be considered in MDT clinics before surgery, and preoperative RT should be considered for all extremity and truncal wall soft tissue sarcomas with high risk features where RT is indicated only. That's my time. Thank you.
Thank you so much, sir. I now hand over the mic to our second debater, Dr. Madhu Sairam. Over to you, sir.
Hi, good evening, everyone. Thanks, organizers of MOSCON, for this opportunity.
Sir, have you?
Yes, I have shared the slide. Okay, So I have been given this tough task of debating against my good friend Dr. Anand Narayanan, and I'm sure I'll be citing all the negatives that he has mentioned in his talk. I will be talking for adjuvant radiation in STS. As he has already mentioned, all soft tissue sarcomas are actually put in one basket when it comes to loco-regional therapies. So loco-regional outcomes, survival outcomes are the ones that we look at, and then complications. And we'll also look at the benefits of IM-IGRT in postoperative setting. And one thing that he has carefully missed out is the use of brachytherapy, which is very important in achieving local control. And finally, the talk that has been given to us is what do we actually practice and the conclusions later on. So as this study has been shown extensively, it is a 5-year result of a phase 3 randomized trial from the Princess Margaret group. And they've shown that the local control rates are similar if we use radiation pre-op or post-op. They also show that the metastatic relapse-free survival and recurrence-free survival are actually similar. Coming out on to this meta-analysis, this again shows that whether we use the radiation pre-operatively or post-operatively, the outcomes are going to be similar. And the overall survival also, there is actually no difference in using pre or post-op radiation. Coming on to survival outcomes in retroperitoneal sarcomas, which I thought Anand would actually mention, in radiation offers benefit whether it is given pre-operatively or post-operatively, and it is one site where it has actually improved overall survival. Coming on to the main thing, that is the complications, you have already seen that there has actually been a doubling of acute complications in use of preoperative radiotherapy. That is quite a bit, meaning the wound complications and the healing rates are poorer in when preoperative radiotherapy is used. See, we do not have any other randomized trial from 20 years since this has been published. So this is what we'll have to be quoting every now and then. Now, if you have to look at one of the recent data, that is the RTOG 0630 trial, which is a multicentric trial from US. This again shows that with the use of IM-IGRT, there is reduction in late toxicity, but there is no change in the acute complications. So whether or not you use a higher end technology, we would still be having higher wound complications if preoperative radiotherapy is used. And let us also look at the data from MSKCC. This is just a prospective series where they have mentioned that using IM-IGRT, the risks of late complications could be encouragingly low. We should also notice that one of the dreaded late complication, which is the bone fracture, is actually much lesser, and it's only grade 1 and 2 toxicity, which is higher if IM-IGRT is used in a post-operative setting. So this actually favors use of post-operative setting, and the late complications could actually be lesser. So these are the late toxicities that we generally talk about: subcutaneous fibrosis, joint stiffness, and edema. And coming on to one other factor that people who propagate pre-op radiation use is the use of reduction in treatment volumes. If 0630 has actually reduced the treatment volumes, we have the Vortex trial, which has actually shown that reducing treatment volumes would still not compromise on the outcomes. So we could still be using post-operative radiotherapy and and I mentioned that brachytherapy is one of the best image-guided radiation techniques. So if we have seen that adding brachytherapy to EBRT has marginally definitely reduced local recurrences, and it has improved 5-year local control in several studies. If we were to look at various studies that employed brachytherapy as monotherapy, we see that the local control rates that are achieved are excellent, and the toxicities are far and few only. And if you were also to see when brachytherapy could be used as a monotherapy, it is in high-grade sarcomas where a negative margin is achieved and the size is less than 10 centimeters. So several of our patients could actually be treated with just monotherapy. If we use monotherapy, then the treatment time is shortened, You are using post-op, so the acute wound complications are less, and we would still be achieving the same local regional control and outcome by using just brachytherapy as monotherapy and drastically shorten the treatment times. If we were to use brachytherapy as a boost, we would still be achieving very good local control, and certain studies somewhere nearing 100% at 5 years is the local control offered by brachytherapy as a boost. And you can also see on the extreme right that the complications rates are not much different. Okay, so if we were to argue for preoperative radiotherapy also, where brachytherapy can be used as boost, you should understand that if a patient turns out positive after a patient has received preoperative radiotherapy, that patient would actually have to undergo another extra procedure to receive brachytherapy as boost. And as we all understand that the acute wound complications take a very long time to settle down, using brachytherapy in somebody who has received pre-op RT is going to be extraordinarily difficult. Okay, so something that we have used in practice over the last 10 years, we have treated several patients with brachytherapy, or at least in the place where I work in Kowai Medical Center, our surgeons encourage use of brachytherapy in most high-grade sarcomas. This is an 80-year-old recurrent sarcoma treated with brachytherapy, and this is another young girl who was treated with just brachy monotherapy for a high-grade sarcoma. And this is another challenging, very large high-grade sarcoma where brachytherapy was delivered for this patient with an open wound through the end of treatment, and then the wound was actually closed. So looking at it, at brachytherapy as a treatment tool, it really helps and actually reduces the total dose of external radiation that has to be offered. Okay, so let us see the trends of use of preoperative radiotherapy. Yes, since 2002, there has definitely been increase in the use of preoperative radiotherapy, but we should see that even now, it is 76% there is use of postoperative radiotherapy in clinical practice. And we have also noticed that pre-op RT is only being used mainly in academic facilities. So for a general practice, I think people still resort to postoperative radiotherapy in sarcomas. Okay, so to conclude, in postoperative radiotherapy, we have the advantage of getting a final proper histology. Brachytherapy, which is one of the best IGRTs, is definitely possible in postoperative setting, could be used as monotherapy, or if used as a boost, would actually reduce the soft tissue dose in the external beam radiation. And as we have already noted that late side effects could be manageable if brachy boost is used. So there is actually no advantage of response evaluation if preoperative radiation is used. So that point is gone. Brachy use is extremely difficult if pre-op RT is used. And a late side effect profile is pretty much the same if IM-IGRT is actually used in post-op setting. Thank you. And as has already been mentioned by Anand, we should notice that if the surgeon is confident of operating this patient there with a negative margin, I think we should definitely resort to surgery at first. But then if he cannot, then probably we should be considering pre-op RT. So some of the specific situations where a pre-op RT could possibly be helpful is when the tumor is involving neurovascular bundle and margins can't be achieved, if a periosteum is involved, or closed margin is expected due to morbidity. Thank you.
Thank you, sir. Over to Anand, sir, for the rebuttal.
Anand,
sir, you have to unmute your mic, sir.
Sorry, I just have one slide to show. Can you stop sharing, Madhu?
Yes, Anand. Anand, by the time you share, you were mentioning about reducing treatment times. If we were to use brachytherapy as boost, then the external beam radiation treatment time is reduced by 2 weeks.
Correct. So coming to the rebuttal. Okay. So the first point is brachytherapy. I agree. But, brachytherapy is applicable for very selective population. The more larger tumor we get, that's what we see in practice. The complications are going to increase even with brachytherapy because of the dose heterogeneity. So it is usually recommended for a smaller tumor less than 10 centimeter. And also for the location becomes important. It cannot be given in multiple, closer to the joint, closer to the neurovascular bundle, closer to the bone. So this will be a bit of a problem. So selection is again the key. Yes, if you are considering brachytherapy, I would agree as a fan. Yes. Again, the expertise involved in brachytherapy. A lot of centers, as we know, a lot of centers are not doing brachytherapy because it involves a lot of learning curve. A lot of people are not experts. So whereas image guided radiotherapy, external beam radiotherapy is being used extensively. One. Second, again, acute wound complications. I agree. Even with modern techniques, we have not been able to reduce the acute wound complications. But again, this is the one slide that matters. What matters most for the patient, whether an acute wound complication, which is usually temporary, or a late complication, usually permanent. So can't we endure for a short term if we can have a better future? That's the only slide I have as a rebuttal. Regarding the treatment time, in preoperative RT, again, there is a phase 2 data. I did not cover it. Phase 2 data saying 5 into 5. That is just like rectum, where we give 5 gray into 5 fractions. There has been a phase 2 data of 5 into 5 in sarcoma as well. So as brachytherapy, EBRT can also be finished in 1 week which is non-invasive and easier to deliver.
But Anand, I think we will slowly get data from several centers where we could possibly be reducing the late toxicity by reducing the treatment volumes. I think Vortex final results would actually be giving us the details.
Yeah. So, but as of now, we don't have any data to say that the postoperative RT results in a lesser or as equal late toxicity as a preoperative RT.
Agreed on that. Yeah. Thank you.
Thank you so much, sir. I now request our expert, Dr. Aswin Nagarajan, who's a radiation oncologist from Chennai, to please give the expert comments. Over to you, sir.
Yeah, thank you. Good evening, Anand. It was a nice debate. Actually, we are all familiar with the post-op RT, but now the trend is towards more of preoperative radiotherapy in soft tissue sarcoma. The indications may be different. For example, if we take a preoperative RT, if it is inoperable, or if the surgery is going to cause significant functional loss, we usually offer preoperative radiation in soft tissue sarcoma. Whereas post-operative indications, everybody knows more than 5 centimeter, it's a high-grade tumor, margin positivity, close margin recurrent situation, deep-seated tumors. These are all the indications for post-operative radiation in soft tissue sarcoma. There are advantages and disadvantages in both these approaches. The advantages being in the preoperative RT is a smaller field size, smaller and there is one more important thing is that there is no hypoxia related to the tumor, which especially being delay in wound healing and wound complications are more with the preoperative RT. And if the surgeon is not able to get a positive, if he is able to get not able to get the R0 resection, then we need to give post-operative RT, which is going to add to the toxicity. So the advantages of post-op RT being the wound complications are less, and complete pathological staging we can get it from the post-operative radiation, post-operative RT in post-operative arm. And the disadvantages being the large field size and the large dose. Usually we give 66 to 70 gray, that is in post-op, and the late complications like fibrosis, edema and stiffness are more in the post-operative arm, and hypoxia is the most important complication which may affect the outcome of the patient, and there is chances for seeding in the post-operative RT. So all the trials have shown the acute complications, especially the NCA trial had shown acute complications are more with the preoperative RT, whereas the late complications are more with the post-operative RT, especially fibrosis, edema and stiffness. But trials have also shown that with the use of IG-IMRT, the complications can be reduced, especially fibrosis, edema and stiffness can be reduced. And the preoperative RT is more significant in retroperitoneal sarcoma, where it has shown OS benefit. and especially in liposarcoma. So to conclude, RT, it has to be custom-made and multidisciplinary approach is needed for delivering either pre-operative RT or post-operative RT. The decision factors, the factors which has to be taken into account before taking the decision would be like the site of the tumor and the size of the tumor and the operability. If the tumor is located in the upper limb, or if it is retroperitoneal sarcoma, or if the tumor is inoperable, I think we can go ahead with the preoperative RT after discussing with the surgeon. If not, if it is in the lower limb especially, or if it is operable, I think we can go ahead with the post-operative RT and with the use of advanced RT techniques like IgIM RT. That's it.
Thank you so much, sir. Thank you, Madhu sir. Thank you, Anand sir, and thank you, Aswin sir. We'll move on to the next part of the session. Our speaker is Dr. Vandana Mahajan, who's a radiologist and PET CT specialist from Chennai, and she'll be talking on the topic Theranostics in NEC, choice of imaging for diagnosis and treatment. Over to you, ma'am.
Yeah. Can you see my screen? Hello, is my screen?
Yes, ma'am. Your screen is visible.
Okay. Good evening, everybody. So I am giving you an overview on the imaging diagnosis and treatment about the neuroendocrine tumors. So as you all know, there is a gamut of investigations which can be done for the diagnosis of the neuroendocrine tumors, which include the molecular, biological, anatomical, or the endoscopic imaging. So now the most common is the CT scan. This is how the patient normally comes to us. You know, the ideal investigation is a CT, and you should always use a contrast study with a multi-detector CT, a power pressure injector with a thin slice, and please use a multiplanar reconstruction because it aids in the further treatment management, as a surgical intervention is the more common treatment choice. So now the MRI protocol, as you all know, is basically a T1 and a T2 weighted sequence. Again, here also I would emphasize that you need to do the T1 weighted contrast sequences and a T2 weighted sequence. Here you can see a lesion in the T2 weighted sequence in the distal body of the pancreas. Now post contrast, you can see the enhancement. It's a very small lesion, and again, as you all know, that the tumors are either the functioning tumors or the non-functioning tumors. So this is the functioning tumors which are generally picked up earlier, detected earlier, resected earlier, treated better because of their functioning properties. Now these tumors, this is the tumor which you had seen earlier in the MRI also. Now these tumors are usually missed by ultrasound because they are too small, less than 2 centimeters. They hardly metastasize as compared to this tumor, which you can see here. It was picked up on a routine ultrasound, health checkup, you know, and this tumor was non-functioning. And these tumors are generally showing cystic components or areas of calcification, and they are locally invasive. Here you can see the large tumor in the region of the uncinate process of pancreas. It is abutting the mesenteric vessel. CT has very beautifully depicted the structure of this tumor. Now, why do we need a functional imaging? Now, the functional imaging not only aids in detecting the primary, it also helps us in finding out the additional metastatic sites. It helps us to prognosticate the tumor. Now, whether the tumor is well differentiated or whether it is poorly differentiated, all these based upon their positivity for the somatostatin receptors or their glucose metabolism. We all know there are multiple molecular and the functional alterations which happen in a cancer cell. Now, the functional imaging is based on these alterations. So if you need to check the glucose metabolism, you will use a F18 FDG PET. Whereas if you need to see a receptor expression or the cell differentiation, you will use either the gallium DOTANOX scans or PSMA. That again depends upon what site or what is the type of tumor we are looking at. So why do you need the somatostatin receptor imaging in neuroendocrine tumors? This thing is because they have specific binding processes, and they frequently overexpress the somatostatin receptors. So not only for diagnosis, for metastasis, but also as a prelude to PRRT. Now you have to differentiate which patients will benefit from octreotide hormonal therapy in functional tumors or PRRT in other tumors. So now the functional imaging, as I told you, is again of two kinds. Now either it is a somatostatin receptor imaging or it is a glucose metabolism imaging, which is the F18 FDG. Now somatostatin receptor imaging is also of two kinds. It is octreotide imaging or DOTA imaging. Now gallium DOTATOC is the most commonly used receptor imaging because it has a higher affinity for the somatostatin receptor 2 and 5. Now these somatostatin receptors are most widely distributed in the body and they are more commonly expressed in grade 1 and grade 2 tumors. Now grade 3 tumors which have a high Ki index or poorly differentiated, for them the glucose metabolism, since it is high, so we use an FDG18 F18 scan. Now why do you need to do a PET or a SPECT tracer? Now gallium DOTA is a PET tracer whereas octreotide is a SPECT tracer. Now octreotide has a long imaging time because it has a longer half-life. So each scan takes over 24 hours as compared to a DOTA scan, which is just over in few minutes. You know, since it has a shorter half-life. Now the radiation dose in a DOTA scan is much lower as compared to a radiation dose in an octreotide scan, as well as the spatial resolution. So the spatial resolution is much better in a DOTA scan and you can detect smaller lesions. You can see the spatial resolution here in the DOTA PET here, and on the opposite side is the octreotide scan. Since poor spatial resolution, so the sensitivity is poor in octreotide scan. Now, why do you need to have a fusion image? Now, the fusion image is to highlight the lesion much better. So here you can see a high uptake lesion in the area of liver. So now once you fuse all the images, you can make out that the lesion is very beautifully depicted in segment 4 of the liver. Again, an uptake in somewhere in the mid-abdomen. On the fusion images, you can pick up that the lesion is in the region of is a small node in the common iliac and another node in the mesentery. So this small sclerotic focus in the bone was again well picked up by the fused image. So another image which shows a small uptake in the mid-abdomen, which corresponds to a small lesion in the head of the pancreas, which is missed on the plain CT. But if you do the multiplanar reconstruction, you can figure out that the lesion is small and an operable tumor. Now, why do you do an FDG PET? So as I told you, poorly differentiated tumors, they are picked up better on FDG PET. Other indication is if you have a suspicion lesion, but that gallium DOTA is negative, but you still have an indication. So you have to check it with the FDG PET, or if there is a progression, clinical or radiological, which is called the flip-flop phenomena. Now this happens in certain tumors when the well-differentiated tumor de-differentiates into the poorly differentiated type during the course of treatment or during the natural progression of the tumor. So now I move on to a few examples. So this is an example of a grade 1 neuroendocrine tumor. FDG PET shows a small lesion which is faintly visualized, but the metastases are hardly seen. The same tumor on the gallium scan, you can see very high uptake in both the primary and the multiple metastases in the bone, in the lung, and nodes also. So another 74-year-old man who presented with dyspepsia. Now endoscopy showed multiple polypoid lesions. Now gallium DOTA was positive, whereas FDG was totally negative. So it indicates that the tumor was a low-grade tumor. The second part is the Theranostics. Theranostics is nothing but therapy and diagnosis. So here in nuclear medicine, it is very easy to switch from a diagnostic radionucleotide to a therapeutic radionucleotide in the same vector. That means that the imaging isotope gallium is replaced with a therapeutic isotope, that is the lutetium. Why do we need to do a PRRT? Is when do we need to do is when there is a positive overexpression of somatostatin receptor 2, when there is a metastatic neuroendocrine tumor which has failed, or multiple lines of therapy, or when there is an inoperable neuroendocrine tumor when you have to downstage the tumor. So what do we do here? We do an initial staging molecular imaging. We do a targeted therapy. We rescan the patient, and if the patient is negative, then we keep it under follow-up or according to the protocol. And if there is a positive scan still, then either we change the therapy or we add with the combined have a combined therapy with the molecular markers which the medical oncologists are dealing these days. Now, how do you select the patients? The selection is based on the Bad-Burka score. All of you will be knowing that it is an objective scoring system. It is based basically on the SUV values. The SUV values can be objectively quantified, and this is the most important indicators. The other is definitely the renal function, the liver function, KI index, etc. So these are few examples of what we have done. So this is a 70-year-old male, and he had a primary neuroendocrine tumor in the pancreas. You can see the primary here with multiple metastases in the gallium. This is the FDG PET corresponding at the same time baseline. Now after 2 cycles, you can see there is a good response in both the primary as well as the metastases. However, after the 3 cycles, there was a small increase in the size of the primary, but the metastasis had decreased. So there was a PET-NET score of 2, and then we had to, the patient was taken up for the next line of therapy, which is the surgery for the primary. This is the next patient. Again, a primary was in the ileum and multiple metastasis. So we gave 2 therapies here. Post 2 cycles, you can see there is significant reduction, but the patient progressed. There was a small uptake in the segment 4. The patient was taken up for segment 4 metastatectomy and the ileal resection. Another patient with multiple metastases in the liver, post 1 cycle of therapy, you can see there is significant reduction in the size of the metastasis. So the patient is still under follow-up. So the take-home message is both somatostatin and FDG PET are important modalities in the diagnosis as well as follow-up of the neuroendocrine tumors. PRRT is one of the efficacious systems for inoperable neuroendocrine tumors because you can have an objective response, you have better performance status, and overall survival is definitely there. It can be combined with biotherapy and combined with chemotherapy in multiple cases. And we are on the way to personalized medicine. We have therapy guidance with peptide receptor therapy, chemotherapy, localized therapy, and molecular therapy. Thank you very much. Any more questions?
Thank you so much, ma'am. Ma'am, we've not received any questions, but just in case, you can answer them on the chat. Thank you so much, ma'am. With that, we come to an end to the sarcomas and NEC session, and we'll move on to our next session. This session is sponsored by Ceylon Labs, and the topic is role of Bevacizumab in ovarian cancer. Our speaker is Dr. S Krupashankar, medical oncologist from Coimbatore. Over to you, sir.
Well, thank you, Kashish. I'll just share my screen and we'll get started. Okay, hope my slides are visible. So a very good evening to one and all once again. And I'm going to quickly take you through the role of bevacizumab in ovarian cancer. So this is a sponsored session by Ceylon. I'm going to just, that's why I've called it why, what, when, and how. This is on the role of anti-angiogenesis in ovarian cancer, how it's evolved. So if you look at it, this is the pathway that we have, quite a complex pathway, if I might put it that way. So whenever you have somebody with an ovarian carcinoma walking into your clinic, the first decision would be whether you do neo-adjuvant chemotherapy or primary debulking surgery. And then your second decision would be, again, I'm sure all of us would be doing paclitaxel, but then would you add bevacizumab as well? What are the indications to add? And then again, your third decision on PARP inhibitors based on the BRCA and the HRD testing as well. So that's how your decision-making process should ideally look like. So I'm going to take you through on the role of the journey of bevacizumab right throughout from diagnosis right until maintenance. So we all know that obviously the data that we've had for PARP inhibitors or even for BRCA mutations is more solely from high-grade serous or endometrioid cancers. We don't have that sort of real data, especially in low-grade carcinomas. When we talk about low-grade epithelial ovarian carcinomas. And if you look at all the approved or even all the phase 3 RCTs that have been looked at for PARP inhibitors, all of them have included only patients with a high-grade histology. So patients with low-grade histology have been excluded from those trials. And low-grade, we know they're more responsive to hormonal therapies or sometimes even immunotherapy, especially if they're MSI-driven. So we know this is the data that we have as far as high-grade serous ovarian carcinomas are concerned. About 10 to 15% can have a germline BRCA mutation, another 6 to 8% somatic, and another 20 to 25% can have HRD or homologous recombination deficiency. So all in all put together around 50%. But this is the data that I'm talking about only in the high-grade serous carcinomas. And this does not apply to the low-grade histologies. So does the histology matter? Definitely yes, like I was alluding to earlier. So if you have a low-grade histology or somebody with a low-grade ovarian carcinomas, then your choice of maintenance therapy would ideally be bevacizumab, because all the studies which have looked at bevacizumab have looked at including low-grade histologies as well. The same cannot be said for PARP inhibitors, where they've only included high-grade histologies. And then the next decision would be, would you like to do only chemo or chemo plus bevacizumab or chemo plus bev and PARP maintenance? We have the data for all of that. So how do we decide? I'll take you through that. So which chemo? I think this is sort of now become standard of care. We've had a lot of data for weekly chemotherapy, dose-dense chemotherapy, as I would call it. The Japanese data was the Songa's data, but that is probably the only data that was positive, because we've had a host of negative studies of late. After that, the GOG 262 study, which was negative. Then the MITO7 study, which looked at probably in the elderly subset of patients who cannot tolerate 3 weekly might be an option. And then we had the ICON 8, which was the last study, which is the largest phase 3 RCT looking at answering that question. Again, a blow for weekly Pacli and Carbo. So 3 weekly Pacli Carbo is definitely the standard of care. Weekly Pacli Carbo, probably in somebody with PS or if toxicity is a concern. What about bevacizumab? Can you do that? Can you do that as a substitute for weekly Pacli? Well, that data basically comes from the GOG 262. We call that a poor man's bevacizumab weekly pack. Can that be used as a poor man's bevacizumab? Well, the answer to that again would be no, because if you look at that trial again, on weekly paclitaxel was slightly better than 3 weekly, but with the addition of bevacizumab, the magnitude of benefit absolutely diminished, which is why probably that was a negative study, and hence that there goes your answer as well. And what about using bevacizumab in neoadjuvant setting? I'm sure a lot of my surgeons, my surgical colleagues as well, would definitely not want me. They're not huge fans of using it in the neoadjuvant setting. But having said that, neoadjuvant bevacizumab has got a DCGI approval, saying that it is approved in the neoadjuvant setting as far as in India is concerned, and that is based on a phase 2 data called the Antalya study. Well, again, if you're looking at doing that, probably that would be more for patients who had stage 4 disease, and stage 4 meaning somebody with pleural effusion or inguinal node or a supraclavicular lymph node being positive. So I think probably in that subset, you might be tempted to add a bevacizumab, but you'll have to remember that you'll have to stop it at least for 6 weeks prior to surgery, because otherwise you're talking about delayed wound healing, higher risks of perforation, fistula formation. All of that is much higher with bevacizumab, and thereby the concern for using it in the neoadjuvant setting. In the adjuvant setting, we have the data from the 218 and the ICON 7, which have looked at adjuvant chemo plus bevacizumab followed by bevacizumab maintenance, and the high-risk subset, meaning somebody who is suboptimally cytoreduced, somebody with ascites, and those were the subsets that seem to benefit the most. So this was the ICON 8 study, which I was just alluding to earlier, weekly versus 3 weekly. Well, the weekly absolutely did not seem to improve on the PFS, which was the primary endpoint. And hence, the negative study, 3 weekly Pacli Carbo still remains the standard of care. So how do you go about selecting the optimal maintenance therapy as far as ovarian cancer is concerned? Well, I think we'll have to take into account the clinical factors, genomic factors as well, like the BRCA, the HRD score, then the safety of the drug, convenience, and patient preference, and last of all, but certainly not the least, the financial constraints as well. So when we talk about anybody with a diagnosis of ovarian cancer, we know this is a disease which is going to remit and relapse again and again. Relapses are the order of the day as far as epithelial ovarian carcinoma is concerned. But when we talk about cure, it's more of operational cure, because we know that, again, they could still have circulating tumor cells, or CTCs, or ctDNA as we call it, which is why probably the concept of MRD, even though that's been mostly validated in hematological malignancies, seems to be working in. And somebody who's probably still has a ctDNA which is detectable on MRD positive, could look at identifying the ideal patients who would benefit from maintenance therapy. So let's look at how it's actually evolved over a period of years, over a decade. So we had the GOG 218 and the ICON 7 about a decade earlier, which led to the approval of Bevacizumab in that setting as maintenance. Then we had the Solo 1 in 2018 for olaparib. And then now we're spoiled for choices. We could do niraparib in the first line setting as well for all comers, irrespective of the HRD. And then olaparib plus Bevacizumab as well, if you're talking about a combo. So I'll quickly take you through that. So this is the data that we had earlier. So if you look at all these trials, the URTC trial, which looked at Neo-adjuvant versus primary debulking, then the GOG 218 Solo 1 primer. So this was the control arm. This is how the control arm looked at if you did not do any maintenance. So approximately 1 year, 10 to 12 months is what we're looking at if you without maintenance. Let's look at how that's actually improved. And we're talking about a duration of maintenance as well. So for Bevacizumab, we know it's either 12 months or 15 months, depending on whether you're following the GOG 218 protocol or protocol. And I'll touch a bit more about that as we move along. And then again, if you're talking about using olaparib, that's for 2 years in patients who had a CR. And in patients who've had only a partial response, you continue it until progression. And niraparib, they looked at using it for 3 years. So that's in effect as to what we're talking about as far as the duration of maintenance is concerned. And again, the magnitude of benefit was strikingly different in the Solo 1 study, hazard ratio of 0.3 and absolute 3.5 improvement in PF, 3.5 year improvement in PFS. But again, that trial only included patients who had a germline BRCA mutation and only 2 patients had a somatic BRCA. So I think that is the reason why you're having that amount of magnitude of benefit with the Solo 1 study. And what about the combination? This is what I was alluding to earlier about olaparib plus bevacizumab. This is an already FDA approved option. And again, they looked at all comers in this study, meaning irrespective of the HRD status as well. Primary endpoint again being PFS. And if you look at the overall intention to treat population, 22 versus 16 months, absolute improvement in the PFS of close to 6 months. But again, when you look at it across the clinical risk groups as well, the magnitude of benefits seem to be maintained in both the high risk group as well as in the low risk subgroup. But interestingly, this is the data that I really wanted to highlight. Look at the HRD negative and unknown subset. Absolutely identical PFS, 16.9 versus 16 months. The curves are absolutely hugging each other. So I think probably in that subset is where you might be tempted to only probably do bevacizumab rather than adding olaparib as well in that subset when you know they're HRD negative. So just to put it across in a cross-trial comparison, that's the magnitude of benefit that we seem to be getting. If somebody's got a germline BRCA mutation or a HRD, then your answer is very clear. PARP inhibitors, for sure, they're here to stay. But if somebody's got a completely wild type and they don't, HRD is negative as well, then the magnitude of benefit really drops. It's almost next to nothing, as I was showing in my previous slide. And that's where probably bevacizumab comes into its own. And again, in the low-grade histologies as well. So what were the key differences between the PRIMA study and the POLA 1 study? Again, the PRIMA study, I think what I've highlighted here is there are strong selection criteria in that they took in patients who had a platinum-sensitive disease, meaning at least 70% had responded to platinum, and that was the CR rate. Whereas if you look at the POLA 1 study, the response rates or the CR rate after chemotherapy was only around 20 to 30%. So again, platinum response was less certain, and that's probably another advantage of doing bevacizumab in that subgroup. And this is again data to show you that probably if you don't have a germline BRCA mutation and you have only a HRD positive, you could probably look at adding bevacizumab as well along with your PARP inhibitors, where the magnitude of benefit seems to be higher. And again, this is only based on cross-trial comparison. Well, again, without HRD, absolutely, this is what I was talking about earlier. Look at the difference between the GOG 218 and the POLA 1 study, especially when they had no HRR or HRD. The magnitude of benefit seems to be higher with the addition of bevacizumab as opposed to adding a PARP inhibitor here. And again, this is only cross-trial comparison, so to be taken with a pinch of salt. But again, given the cost effectiveness and also in a low middle-income country like India, I think probably if you don't have any of those mutations, if you don't have a BRCA or if you're HRD negative, then you are absolutely justified in going ahead with only bevacizumab as maintenance. And again, the other key question, can you use HRR instead of HRD? Are they interchangeable? Absolutely not. Even though we say one is the cost, the HRR is the cost and HRD is the effect. HRD, when we talk about HRD, that's a genomic instability score, which takes into account 3 parameters, which are the loss of heterozygosity, telomeric allelic imbalance, and the large-scale state transitions. And your cutoff needs to be more than 42 or more than 33 in a few trials. So they're not absolutely interchangeable. And we have the data. This is again a subgroup analysis from the POLA 1 study, where they looked at whether HRR panel could actually predict for your magnitude of benefit, and absolutely it did not predict for any benefit at all. So HRD, definitely yes, it definitely did predict for the magnitude of benefit, but not HRR. So if you had HRD positive, yes, you could definitely use PARP inhibitors. HRD negative subset, I'm not very convinced with the data, so I wouldn't really want to get into that. I'd probably say only bevacizumab alone might be a good enough option. So let's look at the two key studies for bevacizumab maintenance. One was the GOG-218, which had 3 arms: chemo plus bev, and chemo plus bev followed by maintenance bev as well. And here, interestingly, they chose the dosing to be 15 milligrams per kg for up to 15 months or 22 cycles. So, and again, in the ICON 7 study, they only looked at using 7.5 milligram per kg for up to 18 cycles or 12 months. So those were the key differences. But if you look at the magnitude of benefit, seems to be similar, around 2 to 3 months. That was the absolute difference in the delta as far as PFS was concerned with both the studies. And interestingly enough, both the studies did not show any improvement in overall survival, be it the GOG-218 or the ICON 7 as well. No improvement in overall survival. Well, definitely the adverse effects were a concern, especially with hypertension, bleeding, fistula formation, and proteinuria. And this is the updated data on the overall survival. Still no impact on the OS. But let me remind you again, even here with the PARP inhibitors, also the overall survival data is still not yet mature. So again, bevacizumab, yeah, it does prolong PFS. And when would you use it? Absolutely, patient should not have any contraindications using bevacizumab. Primary surgery, if it is not optimal, if you have suboptimal surgery with residual disease, stage 4 to begin with, yes. And in case of neoadjuvant, after interval debulk, that's how I would look at placing bevacizumab. So again, in the first line treating, definitely like I was alluding to earlier, if you have a low-grade histology, completely wild type, then you're more than justified in probably opting for bevacizumab alone. And the optimal duration is 15 months only. And this, interestingly, was another study which looked at the optimal duration of bevacizumab. Could it be only 15 months, or could you prolong it up to 30 months? This was the BOOST study. Unfortunately, this was again another negative study. There was absolutely no difference in the PFS, which was the primary endpoint. And even though the median overall survival was numerically significant, this was not statistically significant. Hence, the standard of care still remains 15 months of bevacizumab. And again, you have a host of studies looking at combinations, especially with PARP inhibitors plus IO and addition of VEGF. Basically, you're throwing the kitchen sink at it. You're using all of the most effective agents upfront. PARP plus IO plus VEGF inhibition. And again, all those, we don't have the data yet from those studies, but the initial results seem to be pretty promising. And when we look at ovarian cancer, like I was alluding to earlier, relapses seem to be the order of the day. And they will definitely keep relapsing, but the idea is to make sure that the platinum-free interval is prolonged as much as possible. And that's where maintenance therapy really comes in, because you're ideally looking at prolonging the progression-free survival as much as possible. But is PFS the ideal? I think this is something that's been debated on for ages, PFS versus OS. I think PFS, yes, there are a lot of drawbacks. It's an imaging timeline dependent, depends on when you want to do your scans. And the RECIST criteria, again, there have been a lot of criticisms. More than 20% increase qualifies as progressive disease. What if somebody has an increase only around 50%, 15%? And then immunotherapy, if you're using it, nobody actually uses the iRECIST criteria, which actually should be used to differentiate between true progression versus pseudo progression. Then the non-target lesions like pleural effusion, ascites as well. And well, again, I think Professor Ian Tannock actually alluded to this. He called PFS a flawed study and then profit for sponsor. But I think, given that we're talking about ovarian cancer where, the biology of the disease is such that the patients go on for years together, PFS is probably an acceptable endpoint. And in a nutshell, the NCCN guidelines, if you have a BRCA mutation, I think, yeah, definitely you're going to go in with PARP inhibitors. And HRD deficient, again, you could use a combination. HRD proficient, yeah, the niraparib data is there based on the PRIMA study. But again, I'm not entirely convinced with that. And again, low-grade histologies, like I said, the histology definitely matters. Hormonal therapy or bevacizumab, again, in that setting. And again, to summarize in that, I would say BRCA mutated, again, you follow up your platinums with PARP inhibitors. Deficient, also, you could do a combination of even PARP plus VEGF inhibition. And proficient tumors, only bevacizumab alone might be good enough. So platinum sensitive relapsed, you're talking about doing a platinum chemotherapy doublet, and then if your patient has gotten into either a PR or CR, then put them on PARP maintenance, because platinum sensitivity can be taken as a surrogate for PARP inhibitors, effectiveness to PARP inhibitors. And you could also have data for re-challenging with bevacizumab. Yes, I'll take you through that. Again, this is just the key differences in the clinical trials between both PARP and bevacizumab. All the PARP inhibitor studies required high-grade histologies. Bevacizumab actually allowed for all histologies to be used. And again, a host of studies, out of which chiefly being the GOG213 Oceans in the platinum-sensitive setting, where you look at the addition of bevacizumab as maintenance, and again, has only shown a difference in PFS benefit of around 3 to 4 months, no improvement in overall survival. Can you re-challenge? I mean, and this is interesting because, this is looking at secondary cytoreduction as well. I know we've had 3 studies, the desktop study, the GOG213, and then the SOC1 study, which is a Chinese data, out of which 2 were positive, but the only study which was negative was the GOG213. So I'm going to quickly take you through that as to why the GOG213 was a negative study. Because if you look at it clearly, desktop study, and we had a recent publication in NEGM, the overall survival data, 54 versus 46 months in favor of secondary cytoreduction. But what were the reasons? I think the selection criteria was probably the key difference as far as GOG213 is concerned. Well, they didn't have any predictive models like the AGO desktop criteria or the I model plus PET-CT criteria. And probably that's why lesser number of patients actually had optimal cytoreduction done. But again, the key difference also being in the second-line bevacizumab usage, more than 80% in the GOG213 had second-line bevacizumab, as opposed to only 20% and then 1%. Probably another reason as to why you're having different results across these trials. And then again, the data on PARP maintenance also only around 10% took PARP maintenance. So probably the results could have been different had we had access to bevacizumab or PARP inhibitors. And again, re-challenging bevacizumab, if somebody is actually progressed and then 6 months later or has a platinum-sensitive disease, can you re-challenge them with bevacizumab? Again, this is the Italian study, the MITO16 and the MANGO-OB2 study, which looked at answering that question. Again, a PFS benefit of around 3 months. Again, that was the primary endpoint as well. So you could do that. And finally, before I conclude, I think this is the data looking at a combination of PARP plus VEGF inhibition in platinum-sensitive relapse. Again, another key criticism of this study is that you're talking about platinum-sensitive disease and your comparator doesn't have a platinum. So yeah, that's a caveat, all right. But again, having said that, there was a doubling of the PFS in the intention to treat population of 11 versus 5.5 months. So to conclude, I'm going to say probably not for all. It's definitely industry initiated. Definitely has shown a PFS benefit, but never has been shown to improve the overall survival in ovarian cancer. And interestingly enough, they always say no deterioration in quality of life, but has it improved on the quality of life? Well, not sure about that. Definitely does add to the toxicity. Drug holiday is threatened. Not cost effective, but having said all of that, would I do it in practice for select patients? Absolutely yes. So with that, I'll stop and hand it over back to Kashish. Thank you.
Thank you so much, sir. With that, we move on to the last session for the day. Our session is gynecological oncology, and our 2 chairpersons are Dr. Kalai Chalvi K, Senior Medical Oncologist from Chennai, and Dr. Feroz Rajan, Senior Surgical Oncologist from Coimbatore. Over to you, sir and ma'am.
Yeah, good evening. And it's a pleasure to be a part of this program, MOSCON, and it is very nice to be here. And we will move on to the session now. And Dr. Kripa has covered most of the topics is going to be talked about. And this is on gynecology, and we are.
Himanshu, can you share the slides? The intro slide, please. Sorry, ma'am, please go ahead.
Yeah, the first session will be by Dr. Krishna Kumar Ratnam, who's a medical oncologist from Madurai. It's on working algorithm for HRR and HRD testing in ovarian cancer. What is the ideal sequence in clinical practice? Over to you, Dr. Krishna Kumar.
Thank you, ma'am. And thank you, Kripa, and the entire MOSCON team for having involved all of us. I'll share my screen. As ma'am already told, I think a part of my lecture has been covered extensively by Kripa. Is my screen visible?
Yeah.
Yes. Thank you, ma'am.
Take it to the PPT board.
Yeah. Is it okay, ma'am?
Not yet.
Not yet? Oh, sorry, ma'am. Has it gone to PPT mode, ma'am?
Not yet. Still, we are seeing that.
So should we share the slides?
No, see, mine is animated, so you won't know where I have to stop and where I have to talk.
You can press once again on the full. Or reshare again, then it will come.
Yes, ma'am, I will do that. I will do that. I have had the same problem earlier once. Ma'am, has it gone to the slide mode?
No, it is not.
Oh my God. Ma'am, I'm so sorry. Just
but you
can
can
excuse, I will leave and come back 1 second.
Sir, ma'am and sir, till the time, if you have any comments to introduce the session, we would welcome them.
See, the treatment of ovarian cancer over the last 40 years has changed a lot. And now it's become mostly, most people go to molecular studies right from the beginning itself. After diagnosis, the molecular testing has become part of the diagnostic workup itself. Over last 20 years, we have not had the opportunity to do BRCA 1 and 2 in the beginning itself. Now it's become the mandatory test when you start treating ovarian cancer. And I think our patients are aware of all these testing, and they equally demand that you go for any testing like this. I think we'll have more information on this from Dr. Sujith Kumar. Yeah.
Is it at least now on the PowerPoint mode?
It is not in the.
I think then Kashish has to help me. Kashish, you can start your sharing. I will.
Sure, sir. We'll just share the screen.
Yeah. And also, Krishna Kumar, the cost of doing this molecular testing, I hope you will be able to discuss it in your presentation itself.
I actually haven't done that because there's a lot of coupons and other things going on. So some hospitals have it, some don't. And I have just started. I am a very nascent person for this testing right now. Of course, probably before MOSCON is over, I can put it up in some session.
Yeah, maybe more people will start testing.
Definitely.
After.
You can start now. So.
Yeah, we'll start.
So today we will be running through my lecture. Next, please. Next. So we'll have some basic molecular facts, and then about cancer genesis, and then I'll be talking a little bit about HRR and HRD next, and then what we have from MOSCON 22 to your clinical practice and concluding remarks. There's given 12 minutes for this presentation. So I made it hit crisp. So next slide, please. So it's all about a fine balance. So this we all have learned the basics of molecular oncogenesis, where DNA repair is definitely key and instrumental in the genetic stability. And when there is any defective repair, there is going to be genetic instability, either leading to cancer or a hereditary disease in a person, and will take the patient for a genetic divergence. So this is the basic, and this genetic damage is either at the nuclear level or at the chromosomal level. And this fine balance, next please, is what is actually, keeping people going forward. And this is actually, I should call it an ordeal. So we know that it is happening every second, it is happening every minute, every day in everybody's life. So what saves us really are the repair mechanisms, which save us from these kinds of insults, both external and internal. Next, please. And if we look at the ovarian cancer, what we are talking today, we would be talking about the double-stranded break repair mechanism, basically by BRCA complex and RAD complex, which form the predominant set of genes. And then we have a couple of other genes like the MRN complex, ATM, CHEK2, PALB2, and all those. And these together cause high-fidelity DNA repair, and PAR1 contributes and actually fine-tunes the mechanism of homologous repair in all these DNA damages. Next, please. So this is going to be predominantly the pathway which we are interested in targeting while treating an ovarian cancer. Next. So when we really look at this, and when we try to block these pathways and the damages by homologous recombinant repair, and then there is prevention of carcinogenesis and cells going in for apoptosis. Next. So where did we start searching for this homologous recombination repair genes? Instead of we talking about BRCA1 and BRCA2 earlier, we have started talking about a HRR group of genes. This was from the earliest studies, especially study 19, where olaparib, when it was given for patients, even the last wild type BRCA group of patients derived a benefit. We can see the hazard ratio. They derived a benefit from olaparib. Going on to say that it is just not BRCA, but certain other genes which are also benefited by olaparib treatment. Next. So this HRR group of genes, which is there on the right part of this pie diagram, constitutes almost 50% of the high-grade serous ovarian cancer. And in fact, if we add that small group of P10 and EMSY amplification, probably they are called possibly HR deficient, which probably takes it beyond 50%, say almost 60% of patients may be HR genes deficient. Next. So this is that portion. Next, please. So if somebody really goes on to ask, why are we talking about this HR repair in cancer ovary? If you take a high-grade serous ovarian cancer, and we kept thinking of only germline BRCA mutations, especially since we were interested in hereditary breast cancer, preventing similar cancers in first-degree siblings. It was just 15% which we used to talk. But then when you add a somatic BRCA, where now we are going beyond genetic screening, we are going into therapeutics, it goes to about 25%. And then if we add all the other causes of the HRR gene deficiency, almost 50% of patients with high-grade serous ovarian cancer are going to be HR deficient. Next, please. So how do we detect the HRD in a patient? Either we look for the cause or we look for the effect. So first I start with the cause. So these set of genes which constitute the 50 to 60% of genetic mechanism in a high-grade serous ovarian cancer. Next, please. This huge set of genes, they all contribute to various forms of genetic mechanisms, especially it could be either a methylation of one of the promoter regions, or it may be a genetic mutation or undetermined cause. Next, leading to the DNA repair, which we saw in the beginning. Next, please. And this goes on, next, please, to cause gene instability. And this gene instability is shown as a defect, next, please, while testing these patients. What Kripa was mentioning in the previous talk. Next, please. So it's either by the loss of heterozygosity, what we call the LOH, or the telomeric allelic imbalance, or large-scale state transition. These three defects, or the scars which we pick up on testing, along with tumor BRCA1 and 2, put together forms the basis of HRD testing, which is probably the earliest test to take it up was the Myriad My Choice, and that's why this has been put up on this slide. Next, please. And as Kripa mentioned earlier, there's a score cutoff of 42 to call it either present or absent. And the right part, next please, tells us where we expand the HRD positivity based on the tumor BRCA analysis or based on the genomic instability status. Next, please. So this is another test which is also used. It's from the Strand, and they also almost parallel what is being done by the Myriad My Choice, and they're able to give us a genomic scar code, and the cutoff used in TSS is 50. Next, please. So, okay, now we saw the genetic instability mechanism. We saw what are all these HRR genes, which are not just BRCA1 and 2, but certain other genes. Then we saw about the, so these were the causes, and then we saw the effect in the form of scarring of the genome, which was picked up, and the two common ones used in clinical practice, either the Myriad or the Strand. And of course, we have lot more tests which are all in the pipeline, and many which are used also in India. So once we find that somebody is HRD positive, what does it mean to the clinician? Next. In the first line setting, when somebody is HRD positive, I think this is just a recap of Kripa's talk. It can be used as a single agent or in combination with Bevacizumab in frontline setting, the PARP inhibitors. Next. So this came from one of the earliest trials, the PRIMA, which used niraparib, and they predominantly looked at the platinum sensitivity, which was taken as a surrogate marker of BRCA-ness. Next. And 3 years of niraparib maintenance did show a good progression-free survival benefit. Next. And if you see the hazard ratio, there was a 38% reduction in the risk of relapse or death with maintenance niraparib. Next. Then came the Solo 1 study, which is self-explanatory, and this was predominantly on the patients who are germline BRCA positive. Next. Next, please. Following platinum when they give maintenance, and the Paola 1, which Kripa also touched upon, for the Bev plus olaparib maintenance. Next, please. And the patients who were HRD positive, whether it was due to tumor BRCA or excluding tumor BRCA, but any of the other HRR genes, there's a good separation of curves, but HRD negative patients did not benefit from the Paola 1 study. Next. So that goes to say that in the primary setting, if we have picked up a patient who is HRD positive, we have a choice of PARP inhibition with or without bevacizumab in maintenance. Suppose, what do we do if we pick up a HRD positive patient in the relapse setting? Next, please. We can use it as a maintenance after chemotherapy, or sometimes after 2 to 3 lines of chemotherapy, it can be used as a single. Next. So, the study 19 and the NOVA, looking at either olaparib or niraparib, was studied not just in germline. In fact, if you take the NOVA study, it also included platinum sensitive patients, and it had a further, germline BRCA mutant and non-germline BRCA mutant, and it was analyzed. Next, please. So in the study 19, there was a 8 versus 5 months PFS, significant PFS benefit. Next, please. And if you take the NOVA study, where niraparib was used, there was a 22.1 versus a 10.9 month benefit in the BRCA positive tumor. Next, please. And if you take the non-BRCA positive and the otherwise the HRD positive, it was 12.9 versus 3.8 months. And if you take the entire ITT, next please, it was about 9.3 versus 3.9 months benefit, going to say if we have a patient who is platinum sensitive, who is HRD positive, the olaparib and niraparib maintenance in second line following platinum is once again beneficial. Next, please.
So 1 minute left, sir.
So rucaparib, if we look, we have similar data from the aerial 3 design. Next, please. Which is going to say that there is definitely a benefit on the based on the HRD status. It's quite self-explanatory. Next, please. Next, please. Single agent PARP. Next. This has been proven. You can go down the slides, please. In both all the 3 drugs, the olaparib, rucaparib, and niraparib, based on the HRD status. Next, please. So what does the guideline say? When do we test HRD? In germline BRCA and somatic BRCA testing is done first. If it is negative, we go ahead with an extended panel to check for HRR deficiency. This is there in the NCCN. Next, please. The ESMO also endorses the same. Next, please. Next. This is an algorithm which I have just put up. So if we have a ovarian cancer patient in the primary setting, we all have to do first the germline BRCA, followed by a somatic BRCA if germline is negative. If it is still negative, we can go ahead with an extended testing of HRR or HRD. Based on the use of bevacizumab or no bevacizumab, we can give patient chemotherapy and then stratify them and put them on maintenance with PARP inhibitors or bevacizumab based on the BRCA status. Next, please. So this is just a summary of what, and I think this is exactly what Kripa had put up. Next, please. In the relapse setting, we can summarize it in 2 small words. If a patient is BRCA positive, HRR or HRD positive, or if the patient is platinum sensitive, we have the choice of all 3 PARP inhibitors. Next, please. Next, please. So this would be probably the testing sequence which I would use and which is also endorsed in most of the guidelines. Do a germline BRCA followed by a somatic and then go on for HRD if they are negative. HRD positive CA ovary in the primary treatment, you can use maintenance PARP inhibitor. In the relapsed ovarian cancer, HRD positive patients, platinum sensitive relapse, we have both in maintenance as single agent the role of PARP inhibitors. And I think with that I will stop and I'm happy to take questions. Thank you.
Yeah, that was a very clear presentation by Dr. Krishna Kumar. Very nice, Krishna Kumar. And Dr. Firoz, would you be interested? Yeah, introducing the next speaker.
Yeah, thank you. Thank you for inviting me. Next is a debate. It's a role of maintenance therapy in wild type or low-grade platinum sensitive relapsed ovarian cancers. And I would like to invite Dr. Praveen Kumar from Talisheri, the Malabar Cancer Center, to start the talk on debate on PARP inhibitors.
So can I share my slides?
Yes, sir. Please go ahead, sir.
Yeah. So is it full screen?
Yes, sir.
Yeah. So at the outset, as I begin, so my friend, Dr. Kripa, when he called me, he told me you have to do the debate for role of maintenance therapy in platinum-sensitive recurrent ovarian cancer. So I was very gleefully, I accepted the his invitation. So because there was no way that there is a second thought that there is some other agent apart from PARP inhibitors, and this was a win-win situation for me. But then he called me again and he told that I should be a devil's advocate for role of maintenance in wild type low-grade platinum sensitive recurrent ovarian cancer. So now my present situation was something like this. So I was wondering what to be done. So moving to the topic proper, role of maintenance therapy in wild type low-grade serous platinum sensitive recurrent ovarian cancer. I'll be speaking for PARP inhibitors. So it is undeniable fact that PARP inhibitor maintenance following platinum sensitive recurrent ovarian cancer has been approved. And there are the studies ranging from the study 19, Solo 2, Nova and Ariel 3, which has clearly shown that there is a PFS benefit for the PARP inhibitors. And this larger PFS benefit was seen in patients with BRCA mutation or HRD. But overlooked yet important thing in these studies, that is Ariel 3 and Nova study, was that this benefit was seen, that is PFS benefit was seen even in those with low loss of heterozygosity and those with HRD negative subgroup as well. So what was the common thread? The common thread was platinum sensitivity. Now here, as we see, there is clearly, when there is a platinum sensitive patient who has a BRCA wild type and low loss of heterozygosity, it still showed some benefit. Those groups also showed a benefit. And it was further supported by the Chinese study in which they concluded that platinum sensitivity positively correlated to the effectiveness of olaparib in both maintenance and active treatment setting. So moving on. Yeah. So what are the challenges with recurrent low-grade ovarian cancer? As we know, it is a chemo-resistant subset with overall response rate in the pathetic range of around 5%. So whenever we have tried treatment, the high rates of stable disease, it is believed more due to the tumor biology. So there is technically no effective treatment options in this recurrent setting when we are not able to do surgery for the patient. And speaking about low-grade serous carcinoma, is it a homogeneous entity? No, not so homogeneous entity after all. It is believed that around 10 to 50% of low-grade serous carcinoma tend to have platinum chemosensitivity. They tend to, around 10% of the cases, tend to have BRCA mutation. And still around 10 to 50% may have microsatellite instability. That opens certain avenues for intervening in case of low-grade serous carcinomas. So this has been further elaborated in these studies, which has again highlighted the fact that HR mutation positivity is seen in around 11% to 10 to 11% cases of low-grade serous carcinoma, and histological subtype alone does not provide sufficient information to predict either inherited or somatic HRR mutation. There is something called as PCHK2 immunoreactivity, and which was seen in 7% low-grade serous carcinoma from a study from the US. And it is a surrogate tissue biomarker for DNA damage response, which indicate that there is a potential role for PARP inhibitors in case of low-grade serous carcinoma. So PARP inhibitors, it is not just inhibiting the PARP, it does beyond that. That it can cause release of tumor antigens and increase the chance of PD-L1 action, that is PD-L1 inhibitor, immunotherapy action. It has anti-angiogenic effect and anti-inflammatory effects, and it can inhibit cancer progression, which has been validated from the Alvarez article from Alvarez et al. And my friend, I know my colleague would argue, where is the data? There is no data for PARP inhibitors in low-grade serous carcinoma. But wait, these are new kids. They are just come into the market. Hardly even the approval for the second line came in 2017-18, hardly around 3 to 4 years. So we'll just wait. We are dealing with a rare entity, low-grade serous carcinoma. So over the time, we will have the data, but I have presented my provocative arguments for the favor of the PARP inhibitors in case of low-grade serous ovarian cancer. And obviously, PARP inhibitors are oral tablets. So definitely administration is going to be easier. So yes, there is a role for PARP inhibitor maintenance for low-grade platinum-sensitive recurrent ovarian cancer, which has P53 wild type. So I would stop here, and I will come back on rebuttal after my colleague has presented. Thank you.
I call Dr. Manu Prasad to present his views on VEGF inhibitors. Dr. Manu.
Dr. Manu, you'll have to unmute your mic, sir.
Am I audible?
Yes, sir, you're audible, sir.
And my screen is visible?
So screen is not yet visible.
Just a second.
Yes, sir, your screen is visible now.
Make it full screen.
Yes, sir.
Yeah. Good evening, everyone, and thank you, the organizers, for giving me this topic for debate. And I'll be talking about the role of Bevacizumab as a maintenance strategy in patients with wild P53 low-grade serous platinum-sensitive relapsed ovarian cancer. So my friend has initially agreed that he came here with the expectation of cornering his opponent with all these drugs and new landmark trials. But unfortunately, in reality, in contrast to expectation, this is going to happen, that there is no role for PARP inhibitors, and Bevacizumab is the most suitable available option as maintenance strategy in patients with low-grade serous carcinoma. So a few points about this rare cancer. This is a rare cancer constituting around 5 to 10% of all ovarian cancers, and they are characterized by younger age of onset and by positivity for WT1 ER/PR and a P53 wild IC pattern. And the pathway of pathogenesis is different from high-grade serous carcinoma. It's basically based on RAS, RAF, and MEK pathway. And as Dr. Praveen has highlighted, these tumors are characterized by poor chemotherapy response. Like in first line setting itself, it is around 25%, and recurrent setting it is less than 5%. So there is definitely an unmet need for a good systemic agent in this setting. So we know Bevacizumab is a well-established drug in ovarian cancer in multiple settings, in high-grade serous carcinoma from upfront platinum-sensitive relapse and platinum-resistant relapse. So in platinum-sensitive, we have Oceans and GOG 213 trials where they were shown a benefit, but these are all mainly high-grade carcinoma. So generally, though the recommendation is to be treated in the lines of high-grade serous carcinoma. That is what Praveen also has been telling, like as PARP inhibitors being used in high-grade serous carcinoma, probably they'll have a role in low-grade serous carcinoma also. But we should understand that just because there is no randomized trial in low-grade serous carcinoma, we cannot say there is no agent to effectively treat this disorder. So the absence of evidence is not the evidence of absence, and we have to look through the depths of available evidence and find out information that will help us to choose the right treatment. Also, we are always worried about the evidence pyramid. But in rare cancers, we cannot always focus on the top of the pyramid. Sometimes we'll have to look at the middle portion and the lower portions to get the right information. So as I mentioned, there is no definite randomized trial which addresses the issue specific in low-grade serous carcinoma. But some of the trials which study the role of bevacizumab has included low-grade serous carcinoma. For example, ICON 7 trial, where the upfront bevacizumab was tried, 80 patients had low-grade serous carcinoma, and they've done a separate analysis for this subset. And there was a trend towards better PFS with a RSR ratio of 0.78. Definitely the p-value was not significant, and we do not expect with this much numbers to have a meaningful statistical significance. And the other trial, GOG-213 trial, which has addressed the role of bevacizumab in platinum-sensitive relapse, they've clearly mentioned that low-grade serous cancers were not excluded. And in this trial, 81% had serous histology, and a significant number of patients, 5 to 6 patients, 6% had well-differentiated cancers, and a large number of patients had just moderately differentiated. So many of the patients didn't have a poorly differentiated or high-grade cancers. Though there is no separate analysis available, so this also indicates that there may be a role for bevacizumab in this subgroup also, because GOG-213 has shown a definite PFS benefit as well as a OS benefit in the correct analysis. And these trials use an induction strategy followed by maintenance. And coming to the studies pertaining to low-grade serous carcinoma, we have few retrospective studies which has come out from major cancer centers. This study was from MD Anderson Cancer Center, where they have 40 patients who received bevacizumab from 2007 to 2016, and 22% had platinum-sensitive relapse. So here the clinical benefit rate was 77%, with 30% having stable disease, and overall response rate was 47%. And we have to note that around 7.5% had complete response. So in such a low-grade tumor, they had complete response, shows that there is significant activity for this agent, and 40% had partial response. And this has to be contrasted against the chemotherapy response rate. In the current setting, response rate reported from the same institution was around 5%. Here they've used different chemotherapy regimens, and the median duration on bevacizumab 4 months, and it has gone up to 43 months. And 1/3 of the patients had to discontinue bevacizumab, but major cause was progressive disease. And few patients had perforation. And here the median PFS was 10 months, and OS was 34 months. This was in a pre-treated population. So, and also there is another retrospective study from MSKCC, where they had 17 patients and 15 had an evaluable response. And this is also a heavily treated subset with 3.4 median number of lines being 3.4. And 2 patients had single agent, others had varying combinations. So here the overall response rate was 40%, and clinical benefit rate was 7.5%. Median OS was high, that is 1 or 2 months, and 5-year OS was 68%. Here they used bevacizumab with the dose of 7.5, 15 milligram per kilogram. And another study also used bevacizumab in low-grade serous cancer. This is also a retrospective study. Here, the response rate is not that impressive, but majority of the patients are progression-free, and the median PFS is 48 months. And there is an extended PFS benefit that they had much longer PFS compared to what they could achieve with the prior chemotherapy regimen. And this has gone up to 123 months. And at the end of 32 months of median follow-up, the median OS was not reached. Again, this shows the impressive activity of this drug in this setting. And we know case reports are not of much value, but this case report definitely gives some useful information. So this 39-year-old lady with recurrent ovarian cancer continued to receive bevacizumab for 97 cycles and over the period of 7 years, showing the extended activity with this drug. And also it shows that at least in some patients, they can have it for an extended duration.
So can I request you to conclude, sir?
We have, so this is a diagram showing the activity of drugs and multiple levels of pathogenesis in ovarian cancer. There are hormonal agents, chemotherapy, bevacizumab, then BRAF inhibitors, MEK inhibitors, CDK4 inhibitors, but I cannot see PARP inhibitors anywhere. So despite searching thoroughly, so despite though there are multiple experimental agents, the PARP inhibitors cannot be seen in any of these points. And because bevacizumab becomes important, there is no alternative treatment options available. Because chemotherapy, we know the very low response rates, and hormones are being tried. They also don't have a high quality evidence here. Overall response rate is low as 14%, and clinical benefit rate can go up to 60%. And targeted agents tried were MEK inhibitors. They also have an overall response rate around 15 to 25%. So altogether, bevacizumab will be a right choice as maintenance treatment because there is a biological basis for its action. Even log-grade had increased VEGF expression, report up to 35 to 40% in some of the studies, and definitely have a higher response rate and extended activity compared to other available options. And we have evidence from different level, and we have to keep in mind that this is such a rare cancer. And there is definitely a positive alternative. And this drug is not a new kit, and it is widely available. And year by year, prices are being reduced. So probably it will be as cheap as chemotherapy in a couple of years, hopefully, so that we can use this effective drug as maintenance in relapsed ovarian cancer, low-grade serous ovarian cancer. Thank you.
Yeah, now I call Dr. Praveen for his rebuttal.
I hope this Praveen is still there.
Yes, I have not gone anywhere. So I would like to rebut. One second. Is my screen visible?
Yes, sir.
Yeah, I think it is still in full screen, right?
Yes, sir, it's full screen.
Yeah. So my friend had actually presented a good summary of how bevacizumab wonderfully works in platinum-sensitive recurrent ovarian cancer. But then if we look at the individual data in this study, whichever he has put forth, it is just single center data, and probably 2 or 3 centers from US have published till date. So, and if you see, very few patients actually responded to bevacizumab. And in one of the studies by Grisham et al., whoever those who responded had weekly paclitaxel also along with bevacizumab. And the one patient who had a very remarkable long PFS, again, that patient was combination of cyclophosphamide. So whether it is actually due to metronomic chemotherapy that the tumor has gone dormant, the answer is still unknown. And again, I had already pointed out, low grade, the biology of the tumor is different. So probably the long PFS, the stability of the disease is more to do with the biology rather than the wonder drug so-called bevacizumab. And it is only the initial excitement. There has been no publications after 2016. Bevacizumab has been approved in 2012, and it has been available right from 2005. And retrospective studies and whatever the prospective studies were there, the numbers are very small. And IV administration every 3 weeks. How can you forget about the side effects? All the sort of vascular side effects, the hypertension, all those, it comes with that bag of side effects. And yeah, for me, a big no, because it doesn't work. I have presented my arguments. Well, it is open to the audience to decide. PARP inhibitors, it's a new kid, as I already remarked. So just wait. We will be unraveling more facts about PARP inhibitors, so we can just wait. So I will conclude here.
Yeah, Dr. Kalai, you want to make any comments?
Yeah, see, this was nice because one thing we have to keep in mind is low-grade serous tumors or these low-grade tumors, after initial good surgery, we don't get the, the relapses or the recurrent tumors which are going on for a long time. So if you do the first treatment properly, and the chances of using the drug or treatment for these patients becomes very low. And that is why you don't have much of the studies on either of the drugs. But however, as they say, the industry can, introduce their drugs into any setting. Like if you use the PARP inhibitors, you can put it in anywhere. So like what happened to immunotherapy, pembrolizumab has been introduced into almost all cancers. Something like that you want to introduce niraparib in all settings. But of course, when there is a chance and the patient can be introduced to any one of these PARP inhibitors, whichever is suitable for them. And bevacizumab is one thing where you can use it on any of the settings. When the PARP inhibitors are expensive and patient cannot buy it, and there are more side effects to all these drugs, bevacizumab seems to be, we have more experience and it's easy to use it. And as the situation permits, bevacizumab may be a good choice. But as I said, the chance for using this drug is not so common, like in high-grade ovarian cancers. So I think we should decide on the opportunity and the patient status and use of this PARP inhibitors and bevacizumab. I would use bevacizumab more often than PARP inhibitors, depending on the financial situation of the patient as well as the clinical condition. Dr. Firoz, you want to have a word with that?
No, madam. Please, shall we move on to the next one?
Yeah. And both the speakers have done very well.
Excellent.
Very well. Yeah, I congratulate both the speakers.
Thank you.
Imanji, can you move to the next slide?
Yeah, this will be a panel discussion on role of molecular testing in endometrial cancer by Dr. Anjana Joel, who is a medical oncologist from Christian Medical College, Vellore. And I think the molecular testing in endometrial cancer has come a long way. Like when we started practicing in the early 90s, we used to look at the histology, the usual, unusual histologies. And then depending on the stage, we used to treat the patient. Now, after you get an endometrial cancer diagnosis, you have to go for molecular testing. We have come a long way. Let's listen to Dr. Anjana, who's going to give us on the newer developments on molecular testing in the management of endometrial cancer. Dr. Anjana.
Thanks, ma'am.
And the panelists are Dr. Vishwajit Pai, medical oncologist from Mysore, Dr. Venkata Pradeep Prabhu Koyala, from medical oncologist from Tejpur, Dr. Shrikant Boha, medical oncologist from Guntur, Dr. Amita Mageshwari, gynec-oncologist from Mumbai, and Dr. Rajkumar, surgical oncologist from Rishikesh, and Sharada Melikodi, medical oncologist from Manipal. Over to you, Dr. Anjana.
Ma'am, please note Dr. Shrikant has not logged in.
Okay, thanks. So thanks, ma'am, for that introduction, and thanks to Kripa and the organizers. I'm just going to share my screen. Just a second. Yeah. Okay. Okay, you can see it in the slideshow. Yeah.
Yes, ma'am, we can see it.
Okay, all right, yeah. All right. So this panel discussion is mostly about advanced ovarian cancer. So this will look at the role of molecular testing and immunotherapy in advanced, endometrial cancer. So this is a patient for our discussion for today. So this is a 57-year-old lady. So she was from rural Tamil Nadu. She was diabetic and hypothyroid. She was obese, but she was both these were well controlled. So she actually came to us, or rather she presented in June 2021 with the left-sided hemiparesis, and she was evaluated at a center somewhere down south, and a CT brain was done, which showed a right parietal lobe SOL. So she underwent an MRI, which again confirmed this SOL, and there was surrounding edema with midline shift. And this also showed a lipid choline peak on the MR spectroscopy. Now, at her, so because of all these symptoms, she underwent right parietal decompressive craniectomy and a subtotal excision of this lesion in a private clinic by a neurosurgeon. Now, the only intra-op notes available was that the patient became unstable, and so only a subtotal excision was done. And this histopathology was reported as a metastatic carcinoma there and probable small cell carcinoma. And there she had undergone a contrast-enhanced CT thorax, abdomen, pelvis. And this showed a large mass in the uterus. And then on further probing, she also provided a history of blood-stained discharge per vaginum for 1 month. So then she came to our center in mid-July, and she was ECOG4 with a residual left hemiparesis, and a repeat MRI at our center showed a residual lesion in the right temporoparietal region. It also showed another sub-centimeter lesion in the left cerebellar hemisphere. The PET-CT showed uptake only in the uterus, and there were no other sites of metastasis. So we reviewed the slide, and this was a largely necrotic tumor, which was reported by a pathologist as a metastatic polydifferentiate carcinoma. The IHC profile is there, and there were some focal neuroendocrine markers which were positive, but things like WT1, CK720 were all negative. ER was negative. Our gynae oncologist did an endometrial pipple biopsy, which again was mostly necrotic and tissue and very scanty fragments of poorly differentiated carcinoma. Morphology was very similar to what the slide review showed, but again, both these was too scanty and necrotic for any further IHC or molecular testing. Now, she was discussed in our MDT, and then it was decided to treat her as a metastatic carcinoma endometrium with probably oligometastatic disease. And we went on to, we planned her for a complete excision of this right temporoparietal lobe lesion in consultation with the neurosurgeons, maybe followed by whole brain RT and systemic therapy. And she was deemed by our gynae oncologist as not a candidate for surgery at this point. Now, I'll probably stop here, and maybe I can ask Dr. Rajkumar and then maybe Amita ma'am about what do you think about this MDT plan? Are you okay with this with us delaying the local surgery for this patient, because technically she's oligometastatic? These are the only others. These are the only two sites of disease. Dr. Rajkumar.
Hi, thank you, Dr. Anjana. So I agree with the MDT decision. I think the gynec oncologist made a right decision of not going ahead with the surgery for the endometrial, for the uterus. So first we have to take care of the metastatic disease, and then only we can think about the primary in the endometrium. Though this is an oligometastatic disease, technically the patient has had a bad presentation, right? So she may not be fit for surgery also. So I think the MDT decision is right in that aspect.
I think points probably not in favor of a surgery is, of course, first and foremost is that she's not fit for a surgery, and the fact that she's presented with de novo upfront metastatic disease with what seems like a very strange disease biology with a poorly differentiated tumor, which really vague immunohistochemistry and so on. Amita ma'am, would you like to add anything?
Yeah, so considering that she's not fit to undergo surgery, I would say, of course, not surgery at this point, but down the line, I'm not ruling out the possibility of doing surgery later. Okay, we may not perform surgery for uterine cancer at this point, but maybe subsequently after systemic therapy and when she is fit to undergo surgery.
Yeah, absolutely. I think at this, the key thing is at this point, she's not fit, but we would always want to reconsider it later, provided she responds to whatever treatment she is on. So what we did was we went ahead and did the completion surgery. Her post-op period was uneventful and her neurological symptoms improved. The surgical histopathology again showed this largely necrotic tumor with again a similar morphology and IHC to the earlier biopsy. So then, because she also had another cerebellar lesion, we gave her whole brain RT after that, 30 gray and 10 fractions. Sorry, okay. Now maybe I will ask Vishwajit if you're there. Vishwajit, at this point, what do you think? I mean, what histological subtype would you think of? I mean, we know the various histological subtypes of endometrial cancer. This is a vague IHC. Would you want any other further IHC to help characterize this biopsy further? And, did you think is there any particular subtype which you feel would respond to chemotherapy, would have a better prognosis? And would you want an ERPR testing? Vishwajit?
Yes, ma'am. Since this is an advanced disease, definitely I would do a ERPR testing. In most of my patients of advanced endometrial testing, endometrial carcinoma, I do the ERPR testing. But histological, as you said, this is a strange disease because patient has no intra-abdominal disease and straight away we have a brain metastasis, which is extremely rare. So since one of the reports said that there was a feature suggestive of necrosis and some neuroendocrine features, maybe adding a platinum based, which we are otherwise also do make a difference. So maybe I would again reconsider doing those neuroendocrine markers. But apart from this, I don't think I would add any other IHC tests.
There's no other IHC that you would sort of want to do beyond this. So now in terms of molecular testing, Dr. Sharda?
Yes.
Dr. Sharda? Are you there?
Yes,
okay, okay, Shada. So in terms of advanced endometrial cancer, when would you like to do your molecular testing, and what would you want to do? Would you want to do this at the diagnosis of a recurrence or metastatic disease, or would you sort of wait for a patient to fail, the first line treatment for metastatic disease, and then would you do it later?
Hi, thank you organizers for giving me this opportunity to be part of panel. Coming to this case, Dr. Anand, I feel molecular testing, if in advanced endometrial cancer, should be preferably done at diagnosis. So in this case, probably since the histopath is not very well defined, as you mentioned before, I would still prefer to get some tissue for molecular diagnosis now, rather than wait for later if she responds, and then we might not get a good tissue for recurrence for molecular analysis. Regarding the modality of testing, if the patient can afford, then obviously an NGS panel that looks at the entire set of genes which we can target, at least MSI and HER2, as you've mentioned here in this slide. I would like to look at that, and NTRK might also come into the picture.
If you're doing an NGS, I suppose.
Yeah.
Okay. And this patient, we do have fresh tissue. So we did do the brain again, right? So we do have fresh tissue.
Oh, yeah.
I'll ask Dr. Venkata Prabhu if sir, you're there.
Yeah, I am here.
Yes. So in terms of MSI testing, what percentage of your patients with advanced endometrial cancer do you actually, in your daily practice in our real world, do actually end up having an MSI testing in any modality, IHC, PCR, NGS, whatever?
Theoretically, it is nearly 30 to 40% of MSI positivity. In fact, but in my patients, I have seen, I think 4 out of the 12 patients, they are MSI positive, whom I counsel for the later line immunotherapy. But that is how it is.
Okay, and in terms of your preferred modality of testing, what do you prefer to use? Do you use IHC? Do you use a PCR?
Obviously, IHC to see whether it is DMMR, because it is the easiest available technique.
And most accessible, yeah. And what you wish, Vijay?
I also do most testing by IHC itself, ma'am. PCR I'm not regularly doing.
Okay, and ma'am, what is done in TMH, ma'am? Amita, ma'am?
Yeah, so same here. We do IHC as the primary test. Only for poll we do sequencing, but
yeah, and IHC. Okay, so and
for all, MMR.
Sure, ma'am. And HER2 again. What would be your modality of choice? IHC, and would you sort of want to confirm a 3+ IHC with FISH?
Yes, that's what we follow at TMH.
Yeah, I think that also pretty much the same. I think most of us probably follow the same approach as well. In terms of additional markers, maybe, I don't know, one of the medical oncologists can take this, I suppose. Would any of you would like to do a TMB or maybe a PDL1? And when would you sort of do a somatic NGS? I know, Vishwajit or Sharda, if you're there. Is any, go ahead, Sharda, sorry.
Yeah, no problem. I think when it comes to marker, TMB is a good marker, because there are studies which have shown that TMB more than 10 is a marker for response to pembrolizumab. PDL1 doesn't actually correlate very well. There was only one phase 1 study when it came to PDL1. So despite our other cancers having PDL1 association with the response to immunotherapy, in endometrium, somehow it doesn't seem to correlate. Sorry, the next question is
the somatic NGS. I mean, you said anyway. You said that at diagnosis you would want to do an NGS. So that's probably taken care of. Anybody else? Dr. Venkat. Yeah, Dr. Venkat.
Yeah. So TMB is not. I think it's not a routinely used marker, at least in a clinical practice in India, because it's a quite a challenging test to do. I think Dr. Amita Maheshwari would agree for that. Only in the apex institutions and the institutions where high fidelity NGS is available, it is done. And coming to the TMB, it is mainly used for the research purposes. And we know that in the molecular classification, or the first 2 varieties are with a very high amount of TMB. that is pole mutated as well as MSI high. These have very high much TMB, and which actually belong to type 1 endometrial cancer. Coming to PDL1, just I agree with Dr. Sharda. So PDL1 in many of the cancers, it is prognostic, and like in NSCLC, it is that prognostic, melanoma is good prognostic. But in endometrial cancer, there is no data to suggest its significance as such. And somatic NGS, definitely, at least after progression on chemotherapy, I will consider NGS.
So, and Vishwajit, I mean, is there any, what are the mutations that you're looking for in your somatic NGS? I mean, it's particular to endometrial cancer. Are there any particular subtypes or histological types where you would look for certain mutations?
Yeah. I think Lynch syndrome is mostly associated with the endometrioid variant, and serous is more associated with HER2. I mean HER2 is more associated with serous carcinoma, whereas other mutations like NTR can all constitute to less than 1%, so not very common. So histological, definitely there is some correlation, but I think we need more data on this.
So beyond your HER2 and MSI, any other mutations? I mean, in especially maybe serous or something, Sharda?
I would again focus on MSI, HER2, and NTRK or any of those.
Sure. I think there's some role of maybe, especially in serous PIK3CA mutations can be found, but yeah, especially because we have some therapeutic options for the PIK3CA, things like PTEN and all we may find, but we may not really be able to target, I suppose. In terms of therapeutic significance, I think PIK3CA is one thing we can look for. What about germline BRCA and HRD testing?
So whenever we are looking at the germline panel for endometrial cancer, I think 6 genes are really important. So coming to germline BRCA especially, a minority of cancers definitely have BRCA mutation, BRCA1 in particular. So if I am looking for the germline panel as such in the NGS, I would like to check for 6 genes in particular, that is MMR genes, and then BRCA as well as PTEN, to rule out the germline syndromes as well.
And what about HRD? Any thoughts on that? I mean, Amita ma'am and Dr. Rajkumar also, I mean, if you have anything to add to especially for the HRD and the BRCA.
So I think if it's a serous tumor, I was dropped out in between. I don't know if you have the histology. If yes, if it's a serous tumor, maybe yes, there is a,
Yeah. I think there's some recent data towards looking at HRD in serous histologies, especially some papers coming out in 2020 and 2021. And I think we've already discussed NTREC, so maybe we can move on. So yeah, so I mean, I think we kind of discussed all this. And so our pathologist did not really commit to any particular subtype. They only were willing to say poorly differentiated carcinoma, and they said maybe some squamoid differentiation. IHC was negative for ERPR and P53. HER2 was negative by IHC. And our MSI actually showed a loss of MLH1 expression, and MSH2 and MSH6 was intact, and we didn't have a PMS2. And we also did an MSI by PCR, which was high. And our MSI PCR test is cheaper if you do it like part of the colorectal panel. So the KRAS BRAF also got done with that, and that was negative. Then, this is at this juncture, she was sent to medical oncology. And so on probing, there was a significant family history of malignancy. Now, she had some first cousins on her paternal side who had, some abdominal cancer. Then she had some second cousins with abdominal cancer. There was some breast cancer, and there were some 3 other cousins with lung cancer. I mean, she was a rural lady. She didn't really know much of backgrounds, but we all could figure out that there was some, family history of a lot of abdominal cancers and maybe 1 breast cancer survivor. The lung cancer kind of really didn't fit in with any particular syndrome that we would associate, with her particular presentation. So, Dr. Rajkumar, I mean, at this juncture, what would you be thinking of? I mean, in terms of the pathogenesis or the etiology for her tumor?
I think your MSI is also high, right?
Yes, deficient. Yeah.
So I think we should think in lines of MSI mutation, MMR mutation, right?
Okay. And anyone else wants to add to that? Vishwajit, Sharda?
Yeah.
I think there are all the pointers that point towards Lynch syndrome in this patient. Yeah.
Yeah, probably.
The only I think against is MLH alone, and I don't know whether methylation is a good idea before labeling it as. I don't know if you have facility.
Yeah, we did it. So we'll come to that, ma'am.
Okay.
And the lung thing doesn't fit into the story.
Absolutely. Yeah. I mean, she's 57. She's 57. She's obese. I mean, there are a lot of things which probably don't fit into a Lynch kind of a presentation also.
Yeah, exactly. Yes. It's only isolated MLH.
Yes. So, sorry. Yeah. So now to move on. So, and at this juncture, like ma'am very absolutely correctly pointed out. So would you want any other test? Just looking at a deficient MLH1, is that good enough? Definitely no. We would have to evaluate an MLH1 loss for a promoter methylation. And that actually would help us distinguish between a Lynch versus a sporadic sort of a MSI high tumor. Then in colorectal, so that this is one way of distinguishing. In MSI high colon cancer, there is also another way. You can do a BRAF. You can look for a BRAF. A presence of a BRAF in MSI high or DMMR colorectal cancer is usually associated with a sporadic tumor and not with the Lynch. Now, of course, if both these are negative or normal, then you would move on to your germline testing. So, I mean, ma'am actually hit the nail on the target. Yeah. So she came to us, and so she was still ECOG3. She was conscious. She had some deficits. And so we just said, okay, she's an advanced endometrial cancer, MSI high. And unfortunately, she had an MSTEMI. So she went home for around 2 weeks, and she had an MSTEMI after she went home, and her ejection fraction dropped to 35%. So she's chemo naive, probable HNPCC. And what would be your options of systemic therapy, Dr. Venkat?
So 57 years old female with ECOG performance status of 3, CVA, and obviously with a brain metastasis and MSTEMI. So her non-oncological survival is looks like much less than with cancer itself. So I definitely won't give an option of chemotherapy or immunotherapy in this performance status. I would discuss whether endocrine therapy if she is willing. Otherwise, I will refer her for palliative care.
ERP or IHC was negative.
Negative. Then there is no option of endocrine therapy as such. So in this performance status, with so many comorbidities, I won't offer immunotherapy definitely. Single agent chemotherapy, I might consider single agent taxane if she is fit, but in ECOG3, no treatment.
But I don't know if our main thing is brain. If we consider brain mets, single agent taxane, I don't know whether it will work in this situation.
So WBRT is already given them, so to address that. So there is no other site of disease, only to.
Yeah. Ma'am, 5 minutes left, ma'am.
Okay, sorry. So Sharda and Vishwajit, what would you think? I mean, best supportive care versus definitely not a doublet, I suppose. Maybe single agent immunotherapy, or would anybody want to give chemo and IO? Vishwajit?
Given the comorbid illnesses and the current performance status, I would definitely suggest for a early intervention with the palliative care. But I would definitely consider chemotherapy if improves, if her general condition improves. Probably sometimes we see, post craniotomy, they have residual paralysis. If that is the reason for her ECOG performance since 3, with anti-edema measures, there is a chance that she can improve over the next few weeks. I would definitely consider only if her general condition improves, but otherwise at this juncture, I wouldn't offer her.
Absolutely. And just one point I'd like to drive home is that even in deficient MMR patients, actually in a fit patient, your first line choice should be platinum-based chemotherapy. Your use of, single agent immunotherapy is mostly based on phase 2 data in the second line setting. So your whole thing of biomarker driven treatment in advanced endometrial cancer actually happens in your second line. So this is some data which is looking at single agent pembrolizumab in DMMR endometrial cancer. So I think the most number of patients is probably from the subgroup of the phase 2 keynote 158, and this had around 50 patients with endometrial cancer, response rates of around 50 to 60% and fairly reasonable PFS. Now this patient, there is also one more drug, dostarlimab, which also was described recently in JAMA. So this is again mostly in this subgroup of patients, mostly post 2 lines of treatment, including platinum-based treatment, the response rate is around 40%. Now, this is a fairly reasonable and nice algorithm. So this looks at, again, to use first line Paclitaxel carbo, and then to look at, MSI high and your MS and your TMB, decide versus immunotherapy versus rechallenging with something else. Now, maybe Sujith or Sharda or Dr. Venkat can take this. When would you consider using pembro and lenvatinib in recurrent endometrial cancer?
So it is one of the most prominent and hopeful combination in MSS tumors also. So it works, the combination works in both dMMR as well as pMMR, that is deficient MMR as well as proficient MMR. So in the patients, particularly having proficient MMR status or MSS, to say, they have very limited options, particularly in second or later lines. So in the LEAP trial, which was planned in ESMO 2020, it has seen that this combination works in majority of the tumors in post multiple lines. So in endometrial cancer, there is a separate trial checking this combination, and results are really hopeful. So lenvatinib seems to alter the microenvironment in the MSS tumors. So this is the combination I will choose, particularly in those who are progressing on chemotherapy, post platinum therapy, less than 6 months.
And what about single agent pembro, Vishwajit or Sharda?
Single agent pembrolizumab in patients with the MSI high, but in others
MSI low, MS and pMMR. So non-MSI high. There is some data is there for single agent pembro also. Again, mostly post at least one line of chemotherapy, which is platinum based. So for our patient, what actually happened is she was initially deciding, relatives were very motivated, some second opinion here, there, then they finally decided to try 1 cycle of single agent carbo. Now she had an FN, she had delayed thrombocytopenia, really bad quality of life, she was ECOG 4. They went on to take 2 doses of single agent pembrolizumab. She was still ECOG 4 and she had refractory seizures, heart failure, needing NIV, and finally they opted for comfort care. She passed away after 4 months. So we went ahead and did the hypermethylation status, and this was positive. So this was by this technique called a methylation specific PCR. So then we also involved our medical genetics team because of this family history, and we did a germline testing, and this showed a VUS in this exon 1 of HNF1B. So she didn't have Lynch. So then when we looked at this, we know that these are the 2 types of endometrial cancer. So this whole HNF1B business comes up in mostly clear cell endometrial adenocarcinomas. So maybe she just had a clear cell endometrial cancer. And then we kind of read up a bit more about clear cell endometrial cancer. And what we saw is that this is very heterogeneous subtype, and all 4 subtypes can be there. So you can have patients who have a P53 driven tumor. You can have patients who are clear cell and who have mismatch deficiency. And patients with the P53 are again, of course, aggressive. And these mismatch deficient fellows will have a mixed morphology with clear cell and maybe some endometrioid components. So actually that was our main learning from this patient. And, there was a lot of molecular work also going back and forth. So yeah, so that's the end of our presentation. So our key takeaways today are mostly looking at when to do molecular testing, what, when, and how in advanced endometrial cancer, and the role of chemo or immunotherapy in both deficient MMR and non-MSI high endometrial cancer. And then, of course, this whole saga, which went on to desperately rule in Lynch syndrome, and finally we ended up ruling it out. So that's the end. And thank you. Anybody else wants to add anything? Please go ahead.
If I may, I think molecular testing is coming up in a big way, even in early stage. We have now, deciding the adjuvant therapy also based on the patient's molecular status. So I think in a couple of years, we'll have
this was
more
restricted mostly to the advanced, but absolutely, that I think is a whole panel discussion by itself, I suppose.
Right.
Sure.
Yeah, Dr. Joel, the only point is that I am sure that this patient has not received pembrolizumab in our institute. But do you support using pembrolizumab in a patient with comorbidities and ECOG 4? She has received two cycles post single agent carboplatin intolerance.
I think in terms of tolerance compared to chemotherapy and pembrolizumab, in a patient with a poor ECOG, if a patient and relatives are really motivated, yes, we can use. And in fact, she did receive it at our center only.
Okay.
So, I mean, yeah, so they had a lot of doctors who they were known to, they would go back and forth and, they would take their time, decide and say, I want this. So, but yes, we did treat her with the pembrolizumab, yes.
I think I would like to, a wonderful panel discussion, Anjana ma'am. I'd like to add that we had a patient with excellent response to pembro plus len actually. She was on second line. She came in she was not in, she was ECOG PS2, but her PET shows a very good response after 5 cycles of pembro plus len. The other thing is there is some exciting data on cabozantinib that also seems to work only in a subset of endometrial cancer. But again, it looks exciting as it will be something that we can offer as oral therapy in patients who are ERPR negative, obviously. But that also looks good. Data looks good.
Absolutely, yeah. So, anybody else wants to add something?
Ma'am, apologies, we are running short of time.
Sure. All right. Thank you. Thanks.
Thanks,
Thanks,
Dr.
everyone.
Thank you.
Thank you.
Thanks, everyone.
Yeah,
Good night.
Wonderful panel discussion. And I think we learned a lot, and molecular testing in not only in advanced endometrial, but it also in early endometrial cancer will go a long way. And in fact, I had a patient 13 years ago who had only brain metastases and uterus disease confined. So she had whole brain RT, and then she had surgery for the uterus, and she lived, she's still going on without any chemotherapy, and that was a long time ago. But now the situation is different. I think we need to consider all these molecular studies to come to conclusion on treatment of various aspects, including your immune checkpoint inhibitors. Now we'll move on to the next session, which is a debate. Dr. Firoz, would you like to introduce?
Yes, surgeons have been sharpening their knives after this desktop 3 trials results came out. Now we have an interesting debate by Dr. Sunil Kumar, who is for secondary cytoreduction in platinum-sensitive recurrent ovarian cancers. Over to you, Dr. Sunil. He's a surgical oncologist from Coimbatore.
Sunil sir, you'll have to unmute your mic, sir.
Am I audible?
Yes, sir, you're audible, sir.
Yeah. So is my screen seen?
Yes, sir, it's full screen, sir. Please go ahead.
I'll be speaking for secondary cytoreduction in relapsed ovarian cancer. So as we all know, even after the upfront treatment, there is high incidence of relapse. That too in stage 2 and stage 3 and stage 4 ovarian cancer, the relapse rates are even up to 70 to 80%. So as we all know, the most we need to select, although there are a lot of armamentarium for treating these patients, we need to carefully select our armamentarium, or else these patients fail very badly. So the outcome depends on how we select our armamentarium. So as we all know, in primary setting, the complete cytoreduction is the most important predicting factor for preventing the relapse. So surgeons have started exploring that whether the same cytoreduction, complete cytoreduction, helps in recurrent ovarian cancer as well. So this is when the desktop OVR trial was initiated, where it has been proven beyond benefit that complete cytoreduction is associated with prolonged survival in recurrent ovarian cancers. As this chart clearly says, that complete cytoreduction is the only important predicting factor. And in this trial, they came to a conclusion that how to predict these complete cytoreduction, and it was based on the performance status of the patient, whether the disease was early stage or whether it was completely cytoreduced with the initial surgery if it is a locally advanced disease, or whether the patient has ascites or not, even if ascites is present, if it is less than 500 ml. So based on these criteria, patients were selected, and they found that the rate of cytoreductions has improved drastically. So this was confirmed in all this were confirmed in a prospective trial, which is the desktop 2 trial, and it was the improvement in outcomes are based on these hypotheses. that is the bulk of the tumors was removed, which reduces the increases the chemotherapeutic delivery to these small residue tumor cells and reduces the chance of drug resistance. As we all know, peritoneum has the least blood supply and receives 1% of the entire cardiac output. And we know that intraperitoneal chemotherapy has also been one of the treatment options for these patients. So based on these hypotheses, this was validated in Desktop 2 trial, where it was found that based on these predicting factors, the completeness of cytoreduction was confirmed up to 75% in these patients. So, and this trial formed the base for Desktop 3 trial, which was validated between surgery and only chemotherapy. So this was the Desktop trial design for the Desktop 3 trial, where platinum sensitive or lapsed patients more than 6 months were designated between cytoreductive surgery based on the AGO score. If AGO score is there, they were designated to cytoreductive surgery and no surgery. So patients were clearly selected for the treatment outcome. And it was found that it was not only the PFS, these patients also had overall survival benefit. So this trial clearly states that when we select patients based on the AGO score and the completeness of cytoreduction is there, these patients definitely have overall survival benefit. So the next positive trial was the SOC1 trial, which is a multicenter trial again, which showed a PFS benefit when the patients were completely cytoreduced between the surgical arm and the non-surgical arm. The interim median overall survival was also in favor, but the complete results were yet. In this, the patients were selected based on the eye model along with the PET scan, which apart from the routine AGO score, they also used the CA-125, residual disease after the primary surgery, and amount of ascites, and they categorized these patients to low and high risk. So low risk patients fared better than these high risk patients in these trials. So the one trial that was against surgery was the GOG 213 trial. As we all see, the main criteria for selection of this trial was platinum-free interval, but the surgical selection criteria was given at the discretion of the surgeon, and they received Bevacizumab along with standard chemotherapy in these trials.
So half a minute left, sir.
So although there was no difference in PFS, difference in PFS and overall survival, there was been a lot of limitations in this trial. The further treatment or BRCA mutations were not known, whether these patients are BRCA mutated or not, whether these patients were offered olaparib or no strict selection criteria for into the surgical arm, no definitive surgical technique that was explained in these patients. Ascites, which was used in AGO, and the IWatch was used as an exclusion criteria. And when we looked at the characteristics of these patients, they had fewer recurrence sites. They have selected better patients and better platinum sensitive patients. The median platinum sensitivity period was higher when compared to Desktop and SOC1. And the surgical information was lacking much because there was no clear details on how much was the residual disease and where was the recurrence, whether it was a pelvic recurrence, what was the recurrence after surgery. There was a lot of crossovers which was not mentioned, which could have happened after the trial design. There was difference in the treatment protocol, and when comparing the surgical outcomes, there are more of bowel resections in Desktop 3, questioning the quality of surgery in GOG 213, and the difference in mortality rate, which was slightly significant. So we had 2 positive trials compared to 1 negative trial, and the guidelines are also in favor of secondary cytoreduction. So to conclude, there is no point in debating whether CRS is useful or not. It has proven beyond doubt that it is providing overall survival benefit. But even after so much, we have a 5-year in a recurrent ovarian cancer, the 5-year survival outcomes are decimal, and hence combination of surgery along with targeted therapy and other PARP inhibitors or other treatment modalities would be the way forward to improve the outcome among these patients. Thank you.
Can I call upon Dr. Vikas from Kanpur, who is a medical oncologist and hematologist, who would speak against the role of CRS in platinum-sensitive recurrent ovarian cancers?
Thank you for the kind introduction. I hope I'm audible and the screen is being shared. Next slide, please. And my half debate is won over by my counterpart, Dr. Sunil, as he has carefully selected a very important point that yes, ovarian cancer is a very difficult tumor to choose. The primary challenge is to prevent the recurrence, and when it recurs, the best thing is to focus on optimizing survival and maintain the quality of life. Next slide, please. And very importantly, he has given us some of these factors as how these patients are bio-selected for these dextrop trials. They have been very carefully selected as being platinum sensitive, appropriate prior to the chemotherapies, and also at the same time, chemotherapy has always been given as an adjuvant situation after that. We also have to look as the suitability for the platinum rechallenge, suitability for the maintenance therapy with PARP inhibitors, BRCA, homologous recombinant deficiency, homologous recombinant proficiency, importance of histopathology, and the most important is the role of the clinical trials. Also, always important when they relapse, we have to look at how fit the patient is. I haven't seen a patient who has relapsed with the AOG score, which is performance status 1, SIT is less than 500 ml. Most of us do have a persistent previous comorbidities, toxicities, and patient preferences. Next slide, please. When we look at all these three trials, the dextrop, the GOG, and the SO, all of these trials, there were 3 randomized control trials, as Dr. Sunil told. They were all in addition to the chemotherapy for the first recurrence of the ovarian cancers. So none alone was the standard, only for the surgery. So chemotherapy is here to stay. Chemotherapy will be there to stay. Dextrop 3 and the SOC1 had a very strict defined criteria. Probably I haven't found a single patient. If there is one, it would be lovely to assess it and send it to my counterpart surgeons, because they have a very, very strict criteria, minimal ascites, less than 500 ml, performance status, and all these put into it. Now, if we have to give the recurrent ovarian cancers, the chemotherapies, that's the thing we have to always think. Next slide, please. So we have to look at what is the best, how do we select these patients, as they are whether fully platinum sensitive, that is more than 12 months, they are partially platinum sensitive, that is 6 to 12 months, or they are platinum resistant or refractory 3 to 6 months, or this. There is the quotiental validity based on these relatively arbitrary cutoffs, does not reflect the continuum of platinum sensitivity. And also very important that historically defined platinum resistant may respond to platinum on rechallenge. And that's why the chemotherapy is there, but then definitely the standard of care was and will be the chemotherapies for the relapse ovarian cancers. Next slide, please. And when we define platinum sensitivity, we define as whether they are primary platinum resistant, which is intrinsic to the tumor, that when we give the first line of therapy, it was immediately progressive. The secondary platinum resistance is when you rechallenge it, then it's the resistance. Next slide, please. We don't have any biomarkers as exactly find out as what's platinum sensitive, platinum resistant. Patients should be considered for further platinum therapy when platinum is not contraindicated or they do not have a definitive residence. So next slide, please. Chemotherapy is and will always be option for it if it's a platinum sensitive, rechallenge with the platinum. If it is a platinum resistant, you have multiple options of carboplatin, gemcitabine, doxorubicin, and also the PARP inhibitors. Next slide, please. So when we give them, remember there are 4 phase 3 randomized controlled trials showing a benefit of bevacizumab without any molecular selections, 3 phase 3 randomized controlled trials showing a benefit according to the molecular status, being it a BRCA sensitivity, HRD sensitivity, and HR proficiency. There is 1 phase 3 randomized controlled trial showing a benefit of Sediranib, even though it's not available in India, but yes, we have access to it. And PARP inhibitors maintenance, next slide please, has shown a benefit in the recurrent ovarian cancers, in proven platinum sensitive relapses. The NOVA AL3 analyzed the BRCA HRD groups, and all of them, you could look at the hazard ratios, that's self-explanatory. 0.3 meaning a 70% reduced risk of progression. If you carefully bioselect your patients, carefully give them the right therapies in the right manners, in right way. Next slide, please. That's why the ARIEL3 and NOVA did a very important study that carefully bioselect your patients. That's the way you bioselect for the surgery, bioselect for your PARP inhibitors. And next slide, please. And you could look at those beautiful curves of rucaparib maintenance in these therapies across the groups, BRCA mutant, HRD, and BRCA wild type. Next slide, please. PARP inhibitors have shown monotherapy maintenance role in platinum-sensitive relapse, in complete or even partial response following therapies. Benefit of PARP inhibitors is greatest in BRCA mutated, but is also significant in across HRD positive and BRCA wild type non-HRD ovarian cancers. And they are routinely, we all should be testing the BRCA somatic and germline HRD testing for all our patients. Also, the ARIEL4, the trial, which showed the PARP monotherapy instead of the chemotherapy when they have a multiple recurrent platinum sensitive ovarian disease. Next slide, please. So PARP inhibitors are there and the side effects are very manageable except for the MDS and AML, which are potential risks. Next slide, please. We do also have an option of bevacizumab with 2 beautiful trials of Oceans and GOG 213 with a hazard ratio of 0.48 and 0.63 for these patients. So
I request you to please conclude, sir.
Also is an option for it. Going to the last slide of mine. So definitely all these patients are important. Secondary developing surgery do have a role in first relapse, but they are very carefully bioselected patients. Maintenance therapy with bevacizumab, PARP inhibitors are here to stay. Olaparib, rucaparib, there are multiple options for you. A number of factors do influence a role in it, treatment, and that would be the end of my presentation.
Yeah, thank you, Dr. Vikas. Dr. Sunil, do you have anything for rebuttal?
Yeah, so I would say I'm not against all this bevacizumab or the PARP inhibitors, but yes, in the stream of thinking about these targeted therapy, if we miss on the if we don't select the patients properly, we will miss a chance of having a set of patients who will miss on curative line. I mean, increased OS benefit in those patients who have better outcomes with these absolute selection criteria. So I say yes, they would be needed in subsequent lines of management, because even in relapsed ovarian cancer, the 5-year with all this treatment available is going to be decimal. So these patients should be carefully selected for each of these therapies.
Okay, I think he summed it well, that the case selection is very, very important in the relapse setting, and patients should not be denied the chance of a prolonged PFS, secondary PFS. Can I call Dr. Somshekar to give his expert comments, please?
Yeah, thank you very much. It was very good debate that happened, but I think Vikas got confused. He just summarized the treatment of platinum sensitive recurrence, he didn't cover any aspects of surgery in that. The issue is there is no confusion here. Once you have a ovary, there is an adjuvant treatment. It is like telling upfront ovary, neither chemo can cure nor surgery can cure unless you do both in advanced. The whole issue was whenever there is a platinum sensitive recurrence, you have platinum rechallenge, and when they recur, then you have first line, second line Bevacizumab. In addition to all this, in light of the recent randomized control trial, now surgery adds to that. Means there is no debate that all the recurrent patient needs systemic therapy with or without Bevacizumab when they become platinum resistant as per earlier trial, and also PARP inhibitor during platinum sensitive phase. The only issue is now, based on the 2 randomized control trial well conducted, now we know that the patients should not be denied an option of secondary cytoreduction at some time of the frame. It didn't have to be that they recurred and upfront they have surgery. You give a chemo, then those patients needs to be evaluated in an MDT discipline setting, that there is a role of secondary cytoreduction which has not only DFS but also OS, and then you have your sequential anti-angiogenic therapy and you have PARP inhibitors. Now, Vikas told that I have never seen a patient. We do over 100 recurrent ovarian cancer surgery at Manipal Comprehensive Cancer Center since 7 years. Most of the platinum sensitive recurrence, 2/3, are in extremely good performance status. Ascites is not an issue. It is because those patients are on regular follow-up, most of them. There is a RICE 125 medical oncologist jumps doing PET scan. Most of them are eligible. So we have 2 randomized control trial which says, of course, just because we have hammer, everything is not nail. All patients are not a candidate, but there are a good amount of subset of patients, sometimes more than 60%, who may be explored for secondary cytoreduction in addition to all the systemic therapy that has been enumerated. And those needs to be also looked. Also, there is a phase 3 prospective multi-institutional randomized control trial from Spilot et al., where recurrent ovary with secondary cytoreduction HIPEC has a overall survival. So it is not all fits one, but now the medical oncologists are obliged to have an MDT discussion with surgeon sitting, which patient may be eligible. And the surgical onco is obliged to sit with medical oncology, which patient is not eligible for secondary cytoreduction, and they're better off with systemic therapy. Thank you.
20 seconds just for my rebuttal.
Yes, sir, please go ahead.
Thank you. So I totally agree with Dr. Somashekar sir that yes, with a very high volume center as Dr. Somashekar sir has enumerated as his, there is I totally send all my patients to first the surgeons, and we sit together and see how much they fit into that dinosaur criteria of less than 500 ml ascites, ECOG PS1. And I agree with 7 years experience, probably sir has seen 100 successful cytoreductions. But yes, at the same point of time, what I would say to the majority who is listening is that majority of them don't fit probably into the secondary cytoreduction. Probably they might eventually fit for a third cytoreduction when these therapies tend to respond, because most of them don't keep a rigorous follow-up after a surgery. They tend to drop out with their response, and then they only come back when they have a good volume of disease. So all patients in a nutshell should go to the MDTs. Everybody should take a call, and cytoreduction and systemic therapy should always be discussed together. Agreed.
If patients are being followed up on a regular basis, I do think patients will be picked up who fit in criteria for the AGO or the desktop score or the iWatch criteria. But if suddenly a patient turns up with a massively symptomatic, I don't think that those patients might not be eligible. So again, it insists on keeping these patients on proper follow-up with CA-125 clinical examination, so that those patients can be picked up early, and most of them will be fitting into these criteria.
Thank you so much, sir. Ma'am, can you move on to the next session?
Yeah, the next section will be on the reuse of re-challenging PARP inhibitors in platinum-sensitive recurrent ovarian cancer is the role. by Dr. Govind Babu, medical oncologist from SCG Cancer Center, also president of the ISMPO. We invite you, sir, Dr. Govind Babu.
Thank you, Dr. Kalachelvi. Let me share my screen. So I think we've had wonderful sessions so far. What I'm going to talk is sort of a summary of all that has happened. And if you look at the clock, at this time, my talk is over. So I'm going to talk to you about re-challenge with PARP inhibitors in platinum-sensitive ovarian cancer. You have seen the slide, how we are classifying ovarian cancer based on the molecular data. And this is again reiterating what platinum sensitivity is, essentially based on the time periods at which we see these patients after they have received platinum therapy. And why is this important? It's because we know the platinum-free interval is a surrogate for how well these patients do. And this is a slide giving you the numbers. I won't go into too much detail because of time. And this is talking about why PARP inhibition is important in ovarian cancer. The earlier speakers have touched upon this. So we know that these molecular changes are there in these ovarian cancer patients, and we're taking benefit of these pathways and producing what is called synthetic lethality by using PARP inhibitors. And this is just to show you the time scale of when we started looking at PARP inhibition, when we started understanding DNA damage. And in 2020, we have 4 PARP inhibitors that have been approved. And these are the 4 approved PARP inhibitors that we have. And these are the 4 we can lay our hands on. Talazoparib is not still widely available in India, but the other 3, including niraparib, but the other 2 are easily available. And what is important to remember is the varied activity of each one of these. And the 2 of the things that we must remember with rucaparib and niraparib is that they have off-target kinase inhibition, and that's what is responsible for the side effects that comes with these 2 agents. This is just to talk about the mechanism of action of PARP inhibition. Important is they have inhibition of the base excision repair. They have upregulation of NHEJ, that is non-homologous end joint repair, and also the PARP trapping that occurs, and that leads to the cell death. This slide also you have seen showing you the role of PARP inhibitors, be it in first line, in maintenance, be it as continuous maintenance or switch maintenance. And this is a sort of algorithm put up in 2021 as to how you're going to integrate maintenance into the treatment of your ovarian cancer in first line. And a lot of this has been discussed, including the debates all through this evening. So clinical application of PARP inhibitors also has been discussed. But just to tell you why this PARP inhibitor is important is because of this particular solo 1, for which we have a 5-year follow-up, showing you that the 5-year follow-up holds on to the outcome that is advantageous by using olaparib. This is for rucaparib from the Ariel 4 study, which have shown that as compared to chemotherapy in relapsed ovarian cancer, PARP inhibition is useful. This is data for niraparib from the NGOT over 16 study. And as you can see here, they had 2 groups, BRCA mutant and BRCA non-mutant, the germline and non-germline. And what they showed was that whether it is germline or non-germline BRCA mutation, the use of niraparib was beneficial. And now this is some data combining a VEGF inhibitor with the PARP inhibitors, again showing you that the concept that was thought of has been proved by this study. And again, you've heard so much about HRR and HRD in the past that I don't need to go through this. But again, showing you that if you look at HRR mutational status, this is where the maximum benefit is. But again, in the loss of heterozygosity also, there is some benefit. So coming to the maintenance, this is the data from OV38 study showing you that again in these 2 different groups of BRCA mutated or non-BRCA mutated patients, there is a benefit. So talking about the role of re-challenge, this data is from the NGOT OV38 study, which looked at maintenance olaparib re-challenge after ovarian cancer relapse on PARP inhibitors. So what I showed you, the data with PARP inhibitors was so compelling that people started looking at whether we can use these PARP inhibitors after they have responded and progressed on PARP inhibition, and we can again give them the benefit of PARP inhibition. And this is the data from this study. So the primary endpoint was the investigator-assessed PFS, and the secondary endpoint was looking at CA-125 progression or to death, and time to therapy, first subsequent therapy. They also looked at overall survival and the quality of life issues, which becomes very important, especially when you're treating with these drugs, especially after relapse. And this is looking at the baseline characteristics. You can see that many of these patients had more than 4 lines of therapy, and they looked at platinum-based therapy or not. And again, whether it was BRCA mutated or non-BRCA mutated, they looked at the various parameters. And they also saw what was the prior PARP inhibition that they used. And as you can see here, a large majority got olaparib, but a small percentage got niraparib, rucaparib, veliparib, etc. And they looked at the HRD status as well. Again, a large, about 40% were positive and 37% were negative. So this is looking at the BRCA mutant cohort, and this is the non-BRCA mutant cohort. This is with olaparib, the blue line. As you can see here, there's a clear separation of these 2 lines, and the difference at 6 months and 1 year is so striking in the BRCA mutant cohort. Even in the non-BRCA mutant cohort, you can see there is a difference, although the values are not as high as for the BRCA mutant. This is the exploratory analysis of PFS by HRD status. And as you can see here, whether the HRD was positive or negative, you can see that there is still a difference of the 2 arms, olaparib versus placebo, and that seems pretty significant. So what this study concluded is that in heavily pretreated ovarian cancer, re-challenge with maintenance olaparib following response to platinum-based chemotherapy yielded statistically significant improvement in PFS versus placebo, irrespective of the BRCA mutant status. And olaparib re-challenge yielded clinically relevant long-term benefit, be it BRCA mutant or non-BRCA mutant. And benefit in non-BRCA mutants were seen irrespective of the HRR status. And again, safety, as we all know, we've been using olaparib for pretty some time. This seems to match the safety profile as was when it was used earlier. Now, why are we looking at reusing PARP, and why do the patients become resistant has been a question. So what can you do about it? So this is one study which has shown that PARP inhibition triggers STING-dependent immune therapy response. And therefore, combining PARP inhibitors with checkpoint inhibitors can increase the BRCA-ness and also lead to better outcomes. And this is quite a few years old study. And the hypothesis that this activates the GAS STING TBK1 IFR3 pathway, which is the innate immune pathway, which induces interferon 1, and this increases the immune responses. And therefore, based on this, there is a concept that you can combine PARP inhibitors with checkpoint inhibitors. Now, this is a beautiful review article that I was able to lay my hands on. This is called PARP after PARP inhibition in epithelial ovarian cancer. And this is published pretty recently in the Gynec Oncology reports. And this actually showed data of various PARP inhibitors and how they've been used after their progress after initial use. And they have shown that many of these responses have been stable disease, and some of them have been showing progressive disease. Now, what are the biomarkers that we can look at PARP inhibition? This has been studied in tissue and ctDNA, and some of them that have been clearly shown are the BRCA1 heterozygous methylation, and this confers resistance, whereas if it is homozygous, that confers sensitivity. Others are BRCA1 and 2 overexpression and an overexpression of CCNE1 gene. And this is again just summing up all the mechanisms of resistance to PARP, restoration of HR gene, replication of the fork of the PARP, signal in transduction over expression, and upregulation of drug efflux. So all these needs to be kept in mind, because if we are trying to use or reverse the resistance to PARP, these possible pathways need to be tackled. So overcoming resistance, I already spoke about combinations of the checkpoint inhibitors. The other one is combining VEGF inhibitors with PARP inhibition. So with that, I will stop. And just to tell you that this is a concept that's come in because you've seen so much advantage with PARP, and people are trying to re-challenge once they've progressed after use of PARP inhibitors. Thank you very much.
Thank you, sir, for that wonderful conclusion. I think that's a good conclusion for the session today. And I enjoyed listening to this gynec-oncology session. And I congratulate all the speakers who did justice for the topic. And we learned a lot, and we continue to learn everything about this molecular aspects of treating gynec-oncology. Thank you very much. And that brings us to the conclusion. And I leave it to the organizers.
Yeah, thank you, Kalai. I totally agree with you about learning every day. Thank you.
Thank you.
Over to you, Kashish.
Thank you so much, ma'am. Thank you, sir. I now request Krupashankar sir to say some words before we close for the day.
Sure. So I must say it's been a wonderful day one, wonderful start to the proceedings, and we've had a fantastic session starting with neuroendocrine carcinoma, sarcomas, now with gynec-oncology as well. So I must thank wholeheartedly all the chairpersons, all the moderators, all the debaters, and all the speakers for taking us through the past 4 hours. I think it's been a long time since I've actually sat through all the 4 hours in a virtual conference. So I think most of us have actually been able to do that, which speaks volumes about how well the topics have been. So thanks a lot to everyone for tuning in, and don't forget to join us tomorrow for day 2 at 5:15. Thank you.
Yeah, congrats, Kripa. You've done a good job.
Thank you.
Yeah,
thank you, ma'am.
Congrats and good night.
Thank you, sir. Thank you.
Good night. Good night, everybody.
Good night.
Thank you, everyone. And we request everyone to join us tomorrow at 4:30 p.m. We're going to have sessions on thoracic and head and neck oncology. Thank you, everyone. Good night, and see you tomorrow.